right now. Can you explain what clonus is? So clonus is sort of this odd phenomenon that happens when you have a preeclamptic patient. So when you're assessing for it, you're taking the foot and bending it at a 90-degree angle back and making it relax a little bit and then sort of jerking it back quick. And what you'll feel is an actual beat against your foot. I don't have clonus currently because I don't have preeclampsia, right? So you should have 0 clonus at baseline. If you have beats, that's something that you're tracking when you're doing magnesium checks. If people are on magnesium, that's one of the things that you'll look for. It's not necessarily, if you have clonus, it's not necessarily something bad, but it could be that if you go from 1 beat of clonus to 4 beats of clonus, that's a change. So it's one of those things that you note as a change. Make sense?
Remind the students to use the microphones when they're asking questions.
We don't have microphones.
You don't have microphones.
I was told that the room mics are supposed to work. Or were we able to hear? We weren't able to hear that question in Rochester?
No, we did not hear the question.
The question was, can you explain what clonus is?
Yeah.
Okay. How is everybody feeling for clinical? Does everybody feel like they know what they need to do as far as timeline? No? Yes? You hear mixed responses.
You guys too.
So for those of you who, for my group, for instance, you guys are going to have clinical tomorrow. Your quiz will be due with your worksheet tomorrow. So everything just got bumped back a week. And I believe you also have one more other quiz due that day, right? I think you have a medication quiz.
It's due at the end of the day.
The end of the day. Yep. Yeah, by 11:59. We'll ask Sam. I'm not the full TA, so I only get partial information. So, do you guys feel like a Kahoot would be helpful for some of the antepartum material?
Yeah.
Yeah? Okay. Let's go back to one that I think I made this one from last week.
We're not seeing the slides being sent or the presentation, so if you could ask them to please maybe resend that.
Yeah. I figured he would have checked that when he was in here, but apparently not. I know.
What ball is so much gonna buy you? I forgot what that. Oh, did you ever see like this? No. Literally, she's the one who tends to like yeah, I did not know that.
Nope, that's not what I wanted.
They might need to do something from the control room.
Okay. I don't know how to contact, like I don't know who I should be contacting.
I'm like
It's either Mike or Donald.
I pushed enough buttons that it worked.
We just got it.
Yeah. Okay. Wait. Yeah. Very annoying. Oh my gosh. This is why I became a nurse, because I don't like that.
But I was also like in the it was so fun. Otherwise I got her
there's enough delivery that we don't all
I was in the
Ridiculous. Sorry, guys.
I don't know, others?
Taking the food out of the fridge.
Well, we didn't have, that was what. And now we don't have it. The IT, most people are here. We're good?
Public?
I won't push any more buttons.
What up? I'll show you this. But it looks like almost 5 minutes.
Oh, great. Now I know how to call the wizard.
You don't have to work.
All right.
I'm totally getting what you are. I was like, Mom, it's Thursday. She goes, oh, okay.
It's not all of it, but like, it's like different.
Really? For my clinical group, while we're here and waiting for people to log in, I know it's supposed to snow overnight. A bit of snow. If you get stuck, if your car does not work, call me early. Okay? If you feel like you don't have a reliable transportation. Okay? That's for my clinical group only. I'm not going to pick up every other clinical group. Okay? Good morning. They feel good about links.
Oh, good. Okay, we have some issues. And even in Rochester.
Yeah. This is the one from last week. Yeah, from the end of well, they would have done it.
Okay, but we never got to.
Yeah. Maybe that could have
My mom.
Okay. Okay. We all ready? Got everybody. Okay, not the glue. All right.
That's gonna be every.
Okay. I apologize if there are errors.
Yeah.
Are you valid? How was this meeting?
Yeah, because we did that.
Some of these questions might come from like reading for this week kind of thing. Hey, if you don't know it, you're learning it. Good job.
All right.
You on the blue. So for blue answers, that would be incorrect because the mom already has the antibody. She's not going to create anything. She's positive she's already got it. Okay, her body's not going to create something against something that she already has.
Okay, wait a second. So
He said I don't need that.
you don't, well, to talk to them.
No, he said I don't need it.
We don't, okay.
I know.
Barb, are you guys keeping up on the Kahoot?
Yep.
Okay. Just want to make sure.
Good job, though.
How did everybody do there?
Feeling good?
Good. I see thumbs up.
All right. Talk to me about that answer. Someone who got it right.
That's from the
Yeah.
voice.
I got it wrong, but I realized that with the 10 weeks, is indicative of chronic hypertension because I think it's after 20 weeks it would be gestational.
Good.
Yes, good job.
Excellent.
So some of you who put red for preeclampsia, were you tripped up by the automatic 160 is your severe range marker? Yeah, so sometimes it's that read the whole question, not just see something, click right to it.
Good.
Respond to that.
We're all working harder.
Yeah. Yeah. I don't know how to respond to that.
Why can people tell me a little bit about why they thought low oxygenation? Those that answered it that way. Speak up loud.
The number of blood cells.
Oxygen carrying capacity. Okay, good.
This could be a question thing. I'm not a professional question writer.
Who else thought about that? Okay, so when you think about something that can cause something, usually that's different than something that has a result of. Okay? Does that make sense? That's the best way I can describe why that would not be the answer. That's a different question. Okay? So we're trying to answer these pretty quickly in the time allotted, which you're going to get a little bit more time when you're looking at it. Just make sure you're answering. You're eliminating the ones that you know aren't the correct and then going in between the couple that might be something that you have to choose from. This is something that as we go through each week, I'm going to keep on honing in on that skill because that's what I want you to be learning in this course is how do I determine what's definitely not the answer and then how do I narrow it down to the two that could be the answer. And then from that, what's the best answer most of the time above that certain percentile, okay? Make sense?
Good job.
Okay. So those of you, let's work through that pathophys a little bit about that, right? Because the placenta is going to be a big issue here. And when it's gone, it's going to be a trigger. So those of you that chose true, tell me why you thought that.
There's 33 of you. I know someone
Go
else.
ahead, yes.
There we
Because
go.
of the graph that you drew.
Yeah. Good. Yeah, it's just it's a natural thing. The placenta goes. It's going to be something that all of a sudden I don't need to do for two. So I'm going to it's going to drop sharply. The interesting thing is that if they are a diabetic, guess what? Do you think that they're going to still need this issue of insulin? Who thinks, I want everybody's hands up in Rochester and here, who thinks they're still going to need insulin and all of a sudden we're going to know whether or not they're a diabetic or not? Hands up, everybody. That's a true thing. Because sometimes we come into this, right, we don't know if they're a type 2 or they're previously, we just didn't know. And so if the placenta goes, they're going to still have this need for insulin. It's going to drop sharply, right, the need for it, but they're still not going to be able to bring that blood sugar down. So your postprandial, that 2-hour postprandial, is still going to be above that 140, 130, no matter what we do. Okay? All right, and then we're going to find out by 6 weeks for sure and be able to diagnose her as a type 2. Got it? Okay.
Morgan, you're there. blood pressure of the mom.
Yeah.
So you got a little bit more extra time just to kind of.
You're not gonna do a blood pressure on a fetus.
When you write a Kahoot question, you only have so many characters.
It's worse than Twitter.
So you got to be careful. Okay. All right. So as a part of the teaching, right? The big key things are that you got to watch for is a headache that is unrelieved with what? Tylenol, right? We don't give ibuprofen because that'll keep the little portion of the heart for the baby that it's called the patent ductus arteriosus. That'll affect it. It's a prostaglandin, so it's going to affect it. We don't give ibuprofen. We used to kind of be able to do either one, but Tylenol is the key here. Unrelieved by Tylenol, the worst headache they've ever had, and it just won't go away. Okay. Now, if they've got the blurred vision and the epigastric pain, we know that, right, if that the ALT and the AST of the liver and everything like that could be affected because of that. Okay, so that's an advanced stages of what? What would you guys think? There's a word that starts with a P. Preeclampsia, right? Those are going to be diagnostic criteria that we would know that this patient has hypertension and they've got the preeclampsia. Okay. Those of you that chose reassess vital signs immediately, talk me through that. You're on the right thought. It's going to be something that might be simultaneous, but not something over what we are going to be assessing for. Okay. All right. We've already got that. Okay.
A fetal heart rate, FHR 120, is completely
Ooh, okay. So magnesium sulfate, I want you to all review some of the risks, associated with toxicity, what that looks like. Not necessarily this, okay? Not necessarily this. So toxicity is something that we watch for, but we kind of like them at a specific toxicity. And it keeps them safe, but it means they're very lethargic, they do have a headache, and their reflexes and things like that we're going to be assessing for. But here, we've got a big concern here, okay? So what I'm going to be looking at over the next 3 to 4 weeks is how to help you determine whether or not you're going to do another assessment or you're going to call the MD or the backup, somebody in there for help. What is the signs and symptoms of? Those of you that answered 10, or 10 of you that answer the correct answer, what is this a sign and symptom of? Stroke. Okay, right? With severe preeclampsia, right, we can be creeping up into that. Yes, we're concerned about that BP, right? And we want to get that done, but you got to be able to determine what do I do next, and then start the following trail of what else. When in doubt, is it bad to get another person in the room? Call for your friends? Is it bad after your night? Or no?
I like assessing.
You know what? I have a lot of friends when I work, and those people know when they know that I'm feeling stressed, and so I'm going to get people in there. And when I start getting tired, I'm going to get other people. I'm going to get people in there to make sure that I'm doing the right thing. Doesn't mean you don't know what you're doing. It means you know what you're doing. It means you know yourself. Okay? I'd get somebody in there right away, and I'd be thinking about looking at a kit for seizure. Okay? Go ahead.
I have a question. How does magnesium work? And what would the signs and symptoms of magnesium toxicity be?
Can everybody in Rochester hear that? Should I repeat it? Are you guys good?
So we heard that.
Okay, great. So that's Megan Thompson. Oh, she's here to do one of the lectures too today. So state it again.
So why do we give magnesium with patients that are preeclamptic? How does it work? And then what would the signs and symptoms of toxicity be? So think about preeclampsia, the disease process, and what medication we'd be given to treat that, and what you're hoping to accomplish.
What are we trying to do? Let's first talk about it because I talked about it in my voice thread. So magnesium sulfate is a seizure preventive medicine. It works on its secondary effects. It's a smooth muscle relaxant, right? All of our blood vessels and arterioles, all those are smooth muscle. It's going to relax that area, right? It also works on the uterus. So when you think about preterm labor, it's going to relax the uterus. So when I talked about preterm labor, I talked about magnesium sulfate, and when I talk about hypertension, I talk about magnesium sulfate for its secondary effects. So it's going to relax everything. And in the process, you feel like absolute crap. It really makes you feel bad. And those women that have been on it for 1 to 2 days are just miserable, aren't they? There's no helping them. The fetal heart rate is affected as well. So it relaxes the smooth muscle. What it does is then protects the body, hopefully, from having a seizure. Now, can they still have a seizure? They can. And they can go the opposite way. We can give too much, so they're so relaxed that, again, the smooth muscle that's in every part of your organs, right, and the heart rate, as well as the breaths per minute, go down. So if you have a regular, person that's usually breathing anywhere 14 breaths per minute, and they go down to 10, what would you do if their breaths per minute were 10 per minute? What would you give immediately? Say that loud.
Calcium
What is calcium gluconate?
reversal agent.
Right, it's the antidote. Why is it calcium gluconate? Well, what happens is this type of medicine removes calcium. Magnesium.
Yeah. Sorry.
Magnesium removes calcium out of the muscle. So it's a calcium channel blocker. What am I going to give for the antidote? Calcium gluconate. I'm going to add it back in so that everything will start pumping again. That's how serious it is. Okay, so I want you to always remember that. And that's something that you will need to remember probably for your NCLEX as well. What's the antidote for magnesium sulfate? For your maternal child question. Okay, does that all make sense? Okay, great.
We're good.
35 weaker.
Still pregnant.
Been at work all day. I'm sorry, the characters are so Guys, I'm so proud.
Awesome.
Good job.
All right.
Sweet. You got it.
Excellent. Not everybody answered, but those of you that didn't answer, were you close to this? Okay, we missed about 15 people answering, so, okay.
Oh, because preacher.
We're getting serious.
Like they'll just beat us already.
Pregnant.
Let's start with the distinction between SROM and PROM, so red and green. Why is it not SROM in this situation?
I had that definition, so you go to that slide that I presented on this, it has a definition, and it's greater than a certain amount of hours. Who remembers that? Anybody? 18. In Rochester, 18. Okay? So yes, she spontaneously ruptured, but it's longer than a certain amount of time. Okay? Okay, good. That's probably why some of you might have had some discrepancy there.
Right. Good job. That's just a straight knowledge.
That's just something you gotta know. Okay? Gotta know it.
Last one. So 39 weeks. Pregnant, first baby. Good. Okay.
Good.
I'm glad to see a majority of you got that right. So when we think about first babies, what's true of typically people with their first baby? Are they maybe a little bit hyper aware? A little bit more nervous? They haven't done this before? Not noticing what's necessarily normal? Correct? So she comes in with sort of nondescript, my belly hurts a little. I've had a couple clots. We haven't seen those clots, right? So that's just a quote from her. Do we know that those are clots this big versus just a teeny tiny smear of blood on a tissue paper? That's a different thing, right? If I had said that she has orange-sized clots, what would you be concerned for?
What would you do? What would change if she comes in and she starts bringing her pads? Here you go. This is what's coming out of my underwear. How many? Which we do see. And you've got these saturated pads and you see clots. What would you first do? We would change here. Call for help. Right? She's bleeding. She's actively bleeding. But this isn't the case here. So this is where you say to yourself, okay, what do I need to do further? Do I need to get more assessment or do I need to call the provider? This one is where, just like Audrey's saying, you probably could get a little bit more assessment because you want to know if that baby's living first, right? We got a little bit of belly pain. She's 39 weeks. She's term. So we want to know. Okay.
Is movement, is no movement times 20 minutes normal? Rochester, anybody? Yes, no?
Do babies sleep?
Yes. Baby sleep. It is okay to have periods where the baby doesn't move.
And we do generally say 20-minute cycles. Okay, we do generally allow for about 20 minutes. So the fact that she hasn't, my biggest concern around this one is that she's 39 weeks and she does understand that what the baby's movement is. So that would still be concerning. I'd really want to get her in. I want to get her on the monitor. I want to start assessing, when did you last start feeling your baby? Tell me a little bit about that movement. And then I would go from there to see, do I need to get an ultrasound? Am I concerned with this baby? And then I'll get the fetal monitor strip and it'll tell me what the heart rate is and how much it's bouncing around. We're going to start talking about some of that and what tells me, what that tells me in terms of sort of how the baby's doing in utero, okay? So that's why you would assess the vital signs and get a fetal heart rate prior to calling the MD. Does that all make sense? Does anybody have any questions on that?
Good job. All right, was that helpful?
Yeah.
Yay, nay?
Okay. We're going to keep doing these. Keep doing those.
So hopefully.
Yeah.
All right. Now that Dr. Summernes is here, do we have additional questions that have come up from her voice threads?
Now, this is going to be new this semester, where all of our presentations are going to be taped for you. Okay? The way we had to do it the first week was because we didn't have the correct setup, and so we couldn't do it on YouTube. And so right now it's being all recorded, and it'll be a YouTube link rather than the way we had to do it on an old-fashioned way on an MP3. That's why we had 7 videos. Although for some of you, that might have been really helpful. You had certain areas that you didn't understand, and you remembered which links those were, and then you could re-listen to them. Toss up, okay? So you always get to re-listen and ask questions, and then the Kahoot the next week is going to help you then seal that information, the information we're really wanting you to pass through and understand.
Okay, So, you guys know I'm a labor and delivery nurse. I worked last night, so I see a lot of postpartum complications. I saw postpartum complications last night. When you're a nurse, there are certain trends that you find yourself in. For some unknown reason, the universe just wants you to have a bunch of these experiences. For about the last year, I have been sort of the bleeding queen at Hennepin. I do a lot of postpartum hemorrhages. I do a lot of 3 to 4 liter postpartum hemorrhages, which is a lot of blood, right? Like, let's think about that in liters that you put next to each other. And then we've lost that out of the body. That's a problem, right? So that's become sort of my thing. I do a lot of big bleeding. So that's one of the things we're going to talk about today, postpartum hemorrhage. Nationwide or worldwide, it is the leading killer of women in their childbearing years. It is a huge issue. We're doing a ton of work right now to change the way that we manage and assess and do postpartum hemorrhage. We're going to talk about some of the postpartum infections that can happen. And then some of the clotting diseases that we can have during the postpartum period. So we need to be able to describe what a postpartum hemorrhage is, risk factors, signs and symptoms, and how do we deal with it? How do we make it stop? Because that's our goal. If she just keeps bleeding, she's going to bleed out. How do we make it stop? Same thing for some of the infections. How do we cure it so that that infection doesn't make her septic? She can go septic. That's not good if you have a new baby, right? We don't want to be losing moms. We don't want to lose moms to bleeding. We don't want to lose moms to infection. So let's talk a little bit about the normal physiology of pregnancy. What happens during pregnancy to the blood volume? It's got to increase. She's now trying to grow and supply a fetus. So she has to pump up her volume to be able to then grow and supply that baby. So she has a huge amount of cardiac output going toward her baby, right? She's also in a state of hypercoagulability. So what does that mean? Yeah, you are extra clottable, right? So you have extra factors floating around that put you at an already increased risk for a clot, for something like a DVT, a deep vein thrombosis, right? So there are certain hormones in the body that stimulate contractions. One of those is called oxytocin. So we've got this natural release of this, we call it the love drug, oxytocin. It's the same thing you feel if you are petting your dog and you feel that love towards your dog, you are having a release of oxytocin. That drug, that hormone, is also produced to make contractions. It acts directly on receptors on the uterus to cause cramping and contractions. That's important during labor, right? We need contractions to open the cervix to have a baby. But we also need contractions to shrink that uterus down and constrict after we've had the baby so we can clot off those blood vessels, right? So this is a really important hormone and a really important synthetic drug that we can give people to help stop bleeding. So postpartum hemorrhage is a true obstetric emergency. This is something that is, if we're having a hemorrhage, it's all hands on deck. We need to stop this bleeding. A woman, if she's having a true postpartum hemorrhage, can bleed out in under 10 minutes. She can lose her entire blood volume if we didn't step in. When you see a true postpartum hemorrhage, if you haven't intervened early enough, it can look like someone turned on the faucet and she is pouring blood. And that's scary. We don't want to get to that point. We want to stop postpartum hemorrhages before they get there. We don't want the faucet turned on. We want to just slow things down. So you can have a postpartum hemorrhage after a vaginal delivery. You can have a postpartum hemorrhage after a C-section. You are creating the same kind of wound on the inside of the uterus when that placenta comes off. It needs to cramp down and it needs to heal. All right?
They can mute.
Who can mute?
Rochester needs to mute.
Oh, Rochester, I'm told that you should mute. Does that make sense? Mm-hmm. Okay.
So we don't hear all that background noise.
Got it. Okay. So postpartum hemorrhage, about 3% of all births have it. In the US, we intervene hopefully before we get to a true hemorrhage. So we're hopefully preventing some of that incidence from coming up. A little bit higher for C-sections at 6.4%. We're also doing a major abdominal surgery, so we're having a little bit higher blood loss. So one of these things that needs to be crossed off on this slide that I just didn't get time to edit is greater than 1,500 cc's for a C-section. Cross that line out. That's inaccurate. It's greater than 1,000 for a vaginal delivery and a C-section. That's a typo on my slide making. So that we're going to define blood loss in a quantitative way. What is quantitative? I heard it. Numbers. Quantitative is numbers. This is a new change as of maybe 5 years ago or so. Maybe
3 to 5.
3 to 5 years ago. It used to be that when someone was having a hemorrhage, she is maybe laying in bed, and I go to assess her belly. We'll talk about that in a little bit. And I notice a large amount of blood come out. It would be that the nurse or the physician or the midwife would look at that and say, that looks like about 500. What we found is that even with training, even with extensive re-education, providers were underestimating blood loss by 30 to 50%. So if we think we have a 500 cc blood loss, we've maybe actually come closer to 800, and we haven't intervened because we weren't aware that it was a problem. So we were intervening late. So we changed the way we look at things to be quantitative. So now, when we do blood loss, we're weighing everything. We're weighing things after birth to make sure that we have an accurate weight. If we're going to look at something in grams, if I've weighed something on a scale and it's in grams and it's 500 grams, how many milliliters is that going to equal out? It's an easy one, I promise. 500. It's easy. Grams to mils, you convert directly. So if I weigh something out, I zero out my scale, and it comes out to be 500, I know that I have 500 cc's of blood on that scale. Okay? One of the really important things about a postpartum hemorrhage is that it's happening in a young woman. So that young woman typically is healthy at baseline. We have our outliers that are not so healthy at baseline, but the majority of women, they're healthy at baseline. Their body is ready to react to trauma. It's ready to compensate. It's ready to squeeze down those blood vessels and make it so that she maybe, from her vital signs, doesn't look that sick. The problem with that is that postpartum hemorrhage, in the vital signs, when it shows up, we're way far down the road. We are to the point where we need to be intervening on all avenues. So if her blood pressure is stable during the postpartum period and you're assessing for bleeding, and you are thinking to yourself, you've done this maybe for a little while, and you're thinking, that looks like a lot, but her blood pressure's fine. That's not necessarily the right step to be taking. That's where you have to know your physiology and know your nursing assessment, because you have to know that if she's bleeding and she's compensating, by the time she decompensates, she's maybe lost 3 liters, and that's a problem. Then we're far behind, okay? So, blood pressure in pregnant women is a little bit confusing, especially in the postpartum period. So, it is concerning if it is significantly below her first prenatal baseline. Why is that? If her body has now reset and gone back into, I'm no longer pregnant, and we're below the level where she was before she created additional blood volume for her baby, that's a problem, right? Because at baseline, she's running here. Now she's actively bleeding and she's below where she started. That's a significant change. That's concerning. Question?
Yes.
Is that like an either or for systolic or in diastolic, or does it need to be both 30 millimeters and 15?
Either or. If you're seeing changes on either side, that's a problem. So one of the things about blood pressure that's really important to know at baseline is that your systolic pressure, it's possible to affect that by running up 3 flights of stairs, sitting down, and having your blood pressure taken right away, right? You can change it. You can move it up and down a little bit. Diastolic blood pressure is a much more accurate indicator of what's going on in your body because it's not going to be affected by stress. It's not going to be affected by the things that you're doing externally. It's going to give you those true readings. All right? So let's talk about the kinds of hemorrhage that we can have. We can have what's called an early postpartum hemorrhage. That's in the first 24 hours after birth. The hands down number one, very important to remember, reason you're going to have an early postpartum hemorrhage is atony. What is atony?
Is it one of the clamp down?
Yeah, so the answer here for Rochester, if you can't hear, was when it doesn't clamp down. The uterus is what kind of fibers? What's the uterus made up of? Muscle. Yeah. Your uterus contracts just like your biceps do, right? Or mine, maybe not so much. So your uterus is going to contract. It's this big muscle. It has gone from being 9 months pregnant and big, right? We've seen pregnant bellies. You know what they look like when they're swinging around hitting counters, right? That muscle has been stretched way out. Those fibers are pulled apart from each other. They maybe don't have the greatest interlock as from when they were nice and contracted all the way down in her pelvis. So we've stretched them out, and then we've forced them to expel a baby maybe over the course of 3 days. That muscle has been doing a workout, contracting for days and days and days. So now her muscle's tired. Now her muscle, it's not really feeling going back to its original shape and staying that way, because that's work. It's got to clamp down. It's got to go back, down, 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 and cut off those bleeding vessels from where the placenta has separated. Same thing with a really, really fast labor. We can have that uterus that's stretched out, and she's got a 2-hour-long labor, and her uterus goes, wait, I'm no longer, what's going on here? There's no longer a baby in here. I wasn't ready. Same kind of thing. We've got atony. We've got relaxation. You can also have atony if you've got retained products. So you can have pieces of the membrane. You can have pieces of the placenta left behind. You can have an entire placenta that really just doesn't want to behave and come off. If that's happening, you cannot get full contractility of the uterus. We can see this as an early postpartum hemorrhage. We can also see it as a problem with a late postpartum hemorrhage, which we'll talk about. Lacerations. So lacerations are a natural part of giving birth. Right? Of their first babies, about 80 to 85% of women have some type of perineal laceration. Right? The body's way of stretching. There are varying degrees that we'll talk about. And these lacerations, they can bleed quite a bit. Right? That is a really full tissue. That's got a lot of vascularization. You can also have vaginal lacerations. Maybe there was a little hand that decided it wanted to come with when the head came out, and on the way out it did a little bit of scratching, did a little bit of tearing on its way out. That's an ouchie. That can bleed. We can also have a cervix that maybe got a little bit torn. We're going to talk about all these different types of things. We'll show some pictures. Hematoma. So the difference in hematoma bleeding versus a laceration bleeding is it's concealed. And it can happen quickly. You can go from having a quote-unquote normal-looking postpartum perineum to having a cantaloupe-sized hematoma in her perineum in minutes. And it's intense. And that's still blood loss.
And very painful.
And excruciating.
Big.
Yeah, they'll be backing up the bed. Okay, does the physiology behind early postpartum hemorrhage click? Does that make sense? Okay. So when we talk about atony, we talk about it in terms of what the fundus feels like. What is the fundus? Where is the fundus? Anybody?
Lower abdomen.
Describe it in terms of where it is on the uterus.
Top of it. Is that what you said?
Did I hear top? I thought I heard top of it. It is on the top of the uterus. So let's talk about the way that the muscle fibers of the uterus are run. At the base, in the lower uterine segment, they're circular. Okay, they run along the bottom. Over the top, they come up and over. Because when we want to have a baby, we need that baby to go down, right? We got to squeeze that baby down toward the cervix, down and out, okay? So when those fibers are going to contract, they're going to contract this way to bring that uterus down, okay? So the fundus is the top of those fibers. When it's nice and firm and rock hard and it's contracting like it's supposed to, that's what it feels like. It feels like a ball. Maybe it's cantaloupe size, maybe it's orange size, maybe she's had a lot of babies and it's a little bit bigger, maybe she's had twins and it's a little bit bigger, but it will feel like a ball of fruit when you feel it. So if it's boggy, you're not going to feel it. That's a problem. If you don't feel a fundus in the postpartum period, you have a problem. Okay? Because that means that that muscle has relaxed. We've opened up space. We can see it in that bottom picture. We've opened up space for bleeding to get entrapped. Okay? Now maybe we've bled into that space for an hour and we've got 600 cc's worth of blood sitting in her uterus. And when we push, we're going to have that clot come out and then we're going to actively bleed more because that fundus still isn't clamped down. Okay? So if we don't feel a fundus, it's a problem.
And you want to assess it in terms like fundus firm
Yes.
and where it's located. And so that's
Yes.
going to translate into the clinical experience that they're going to ask you what's the location of the fundus and it's in relationship to the umbilicus and whether or not it's firm and below it or underneath it. And so your instructors will be talking to you a little bit about this. It's one of your number one things you're going to learn that's extra in terms of your assessment skills because you know all your physical assessment, heart, lungs, all of that. This is one of those 7 B's that you're going to learn, and it's learning how to assess the belly and the fundus, the tip of the uterus. Does that make sense for everybody? Okay.
So risk factors. We talked about a couple of these. One of the biggest risk factors for having an early postpartum hemorrhage is grand multiparity. What is that? Anybody? If you are a grand multip, that means that you have had pregnancies greater than 5 times. Okay? That uterus has been stretched and contracted, and stretched and contracted. And we've done it a few more times. Maybe you've had 10 babies. Maybe that uterus now has decided, I am disinterested in contracting down again. Okay? Lady, I'm not doing this. All right? We're done here. That uterus stays relaxed, we've got bleeding. Because that muscle is tired, it's been stretched and re-stretched. It's as if you sprain your ankle. If you sprain your ankle and you stretch out those ligaments enough, that ankle gets loose. It doesn't really want to behave the way it did before, right? Same thing with the uterus. History of a postpartum hemorrhage. If she's bled with her first baby, there's a good chance she's going to bleed with her second and her third and her fourth. So we are going to be active on those people. Over distension, we talked about that. That's big uteruses, multiple babies, big babies. Polyhydramnios. That is having more than average amount of amniotic fluid. That's having a lot of fluid in there. So you've got baby, you've got placenta, and you've got excess fluid stretching out the uterus. Lots of intrapartum factors as well, okay? Oxytocin, if we're going to use that as a drug to help get your baby out during labor, your body is being exposed to both endogenous and exogenous oxytocin. Okay, so that's, we make it in our body, we give it to you. You're being exposed for a long time to high levels of oxytocin. You're going to burn out those receptors. Those receptors are going to get sick and tired of having you throw oxytocin at them. So then when we need it postpartum, when you're going to need to have that uterus clamped down, they're burned out. They're sick of that, right? We've seen that show and dance. Now we've got that relaxation because we're not responding. Chorial, infection. things don't respond very well when they're infected. They're not very interested in clamping down. Chorioamnionitis, also called triple I. We're starting to see things change terminology-wise. Prolonged labor, same thing with that oxytocin exogenously. Prolonged labor, you're seeing a long time that muscle's working. Precipitous births, we talked about that. That's happening very quickly. C-sections or vacuum extractions. So that's when we're helping pull on the baby's head from below. We're helping that mom with a little bit of effort from below. We're speeding things up for her. We're maybe increasing tearing. Okay? If she's had a long third stage, so when we talk about stages, our third stage is the time to that placenta coming out. Normal, average, is considered 30 minutes. Okay, we want that placenta out in under 30 minutes. If it's over that, then we can start to have concern for bleeding. General anesthesia. All right, we're relaxing everything. Preeclampsia, risk for bleeding. Talk to me about that. Talk to me about the vascular changes of preeclampsia. I know somebody can think through this.
Start with blood pressure.
What's happening with the blood pressure? What's happening with the responsiveness of the body? Because we've had this increased blood pressure. Less vaso... I'm blanking on a word. I'm sorry.
Vasodilation.
Yes, less vasodilation.
The less blood flow is able to get, so the amount of pressure, that's why the blood pressure goes up, the pressure that has to be exuded to get through the blood to oxygenate all the organs is up, right? So the pressure is really high. That resistance that happens causes a major issue with the factors that go along with blood clotting. Okay? It starts to put the patient at high risk in sort of an alert status, and it's usually caused by inflammation. Starts this process, okay? In their notes.
So let's talk about medications. How do we stop it? How do we prevent it? The biggest thing that we use is oxytocin. We call it Pitocin. PIT. That's the way you'll hear us talk about it. It contracts the uterus, just as it does when you produce it naturally. It can be given in a few different routes. IM, IV, diluted in a liter of saline, and IU. IU is intrauterine. So if we're in a C-section and we're really having bleeding and it's not controlled, we can inject oxytocin, PIT, right into the uterus and say, you got to react right now, muscle. Okay? Methergine. Methergine is a fabulous drug for bleeding. It's so good. It also can be given IM in the immediate postpartum bleeding scene. And it can be given PO if you've got somebody who's just continuing to have some bleeding, if we need her to just have a little bit more coverage. You can give it for that next day. You give it about every 8 hours to help control and help encourage that body to stay clamped down. One of the biggest things you need to know about Methergine, super, super, super important, highlight this. It is not used with hypertensives. It can throw them into a hypertensive crisis. Okay, so if we have a preeclamptic, we are not using Methergine.
Right, really the action of it.
Yes, because it's contracting your smooth muscle. It is further bringing that in and further increasing pressure. Make sense?
Okay, so when you think about these two types of medications, oxytocin is going to be a very generally used within your scope of practice medication. But if you have to move up a little bit and use a different medication, it most likely will be under the management of a nurse midwife or a physician. So when you're thinking about, well, I've already done this and I'm in that early stages of postpartum hemorrhage and we've gone through enough Pitocin, we've done these other things, we might need to move it up. That's when you use Methergine. Okay, when oxytocin isn't working, you're going to move to Methergine. But you've tried all of the other things. You don't just all of a sudden go to Methergine. Okay?
So a couple of the other things that we can use, two different options, misoprostol, otherwise called Cytotec, or carbimazole, otherwise called Hemabate. Okay? Cytotec is another drug that's used for induction of labor. It helps soften out that cervix. It helps with contractility, right? So 2 different routes to give this. We are moving more toward doing this in the cheek, right? We used to always give it rectally. We always used to give 800, 4 little pills rectally. Now we're moving a little bit more toward knowing that the absorption is better in the cheek, okay? A little bit lower dose, you use between 400 and 600.
Do you guys want us to know the generic or trade names of the medications for like just test purposes?
Good idea. Good question. Most often, you're going to need to use the generics, so you'll use, and most often it'll be both will be presented. Yeah. That's a good question. Yeah.
So last one, Hemavate. Of the drugs that control bleeding, this is probably my least favorite because of the way it makes the nurse deal with the side effect. When we talk about diarrhea from Hemavate, it is fast and aggressive. It is so much, okay? It is one of those things that if I know someone's getting Hemavate, I'm putting them on 7 different chucks because we're just going to have to clean and we're just going to have to help her through that experience of having just given birth, having had bleeding, and now she's having this terrible diarrhea that she cannot control. It's much like a C. diff kind of situation. It works on contractility of the uterus. It's given in 250 microgram IM doses. We can give this every 15 minutes. It's a great one to keep rebumping. Okay, we're not controlled yet. All right, we got to give another dose. Contraindications, super important. Asthma. Someone with asthma, whether it is mild, moderate, severe, if she has an inhaler, she is not getting Hemavate. Right? So what do we do? We've got bleeding. What are your nursing interventions? First, when someone delivers, the way you're going to do fundal massage, so that's when we touch the uterus, we'll talk about what that means in a minute, is every 15 minutes for an hour. Then we're bumping to every 30 minutes for an hour. All right? Then we're every 4 hours times 2. Okay? Make sense? If I have someone who I do 4 15-minute assessments on, and now I'm technically on my 2nd hour, and she has bleeding on that last one, I'm not automatically, because I've hit that 2nd hour, going to let her go a half hour, right? If I express a large clot, I'm going to reassess, okay? Because at that hour mark, we should feel like we're a little bit more comfortable giving her a little bit more time to see what her uterus is going to do on its own, right? We're not actively massaging every 15 minutes. Things that you're looking for. Initially, when you have a birth, there's some free flow bleeding, right? You might see free flow bleeding when the placenta is ready to come. There might sort of be a gush of bright red. Then, immediately after the placenta, that uterus should start to clamp down. That free flow bleeding, like you turned on a faucet, that should really quickly start to go away. Okay? So you will have the provider in the room from the time baby, placenta, repair of any lacerations, right? The provider will be at the bedside. So that's something that you are working on doing a fundal massage while they're working on placenta or repair, and you're assessing during that time, but you have them and you're working as a team during that time. Right? It's after the provider leaves that it falls on you to know how to do fundal massage, to know what's abnormal bleeding, and to know when to call them back. Okay? Some of this takes time to learn. It takes time to know what's quote-unquote normal bleeding. So if you have someone who's an hour and a half out from birth and you have a lot of free flow bleeding, you get friends in the room. Okay? You don't mess around. You don't have her try to get up and see what happens and see how she feels. She's having a lot of free flow bleeding, you get friends. You get another RN because you need someone to help you, and you get a doc in the room, or a midwife. If she's truly having a postpartum hemorrhage, we need fluids going. Okay? She is actively losing, so we need to start replacing, even if that's just with IV LR volume. Okay? Maybe we'll replace with blood later, but right now we just got to keep her tensive, right? We got to keep her blood pressure up. Sorry, I got a cough. Your other RN, if you are her main RN, you're going to start directing your other friends who have come in to help you to do things in the room. Maybe that second RN, she's doing vital signs. She's on it. She's got it. She's putting a pulse ox on your patient, right? Maybe we need some oxygen to help oxygenate the blood that's still within her body, right? We want to bump up that oxygen because she's losing red blood cells. She's losing her oxygen carrying capacity. Oops. Oh, that was the right way. You're going to verify all your orders that you've got standing, right? When the patient comes in labor or for an induction, she has standing orders for all of the postpartum medications because we know that speeds up the time in which we can get people meds. You need to know whether your patient's hypertensive. Maybe she wasn't preeclamptic when she rolled in the door, and throughout labor, her blood pressure has gone up. You got to know that. You got to be able to say in an emergency, oh, I need to remind you, she's actually hypertensive. We maybe should think about giving another med. Because maybe in that moment, that provider is doing a million things and didn't remember she's hypertensive. That falls on you to know it. Okay? That's one of those nursing things. You need to know she was asthmatic. Maybe that provider ran from 3 different births in 15 minutes and is just trying to catch up and get there, right? If they order Hemabate on your moderately asthmatic patient, are we automatically just going to give it without thinking about it? No, you got to know the contraindications. If someone is bleeding, they're having that free flow bleeding, your hand doesn't come off their belly. You continue to massage their fundus. Because if you leave the room, she's going to keep bleeding, and that massage that you're doing is actually stimulating muscle fibers to contract. Okay? So we're trying to stimulate that contraction. Your hand stays on her belly. All right, you're directing other people to do vital signs, put a second IV in, that kind of thing. Something else that can cause bleeding is a full bladder. Okay, there's only so much room in your pelvis. If your bladder is full, and it can get quite full, up to a liter if you haven't emptied it properly in postpartum, very quickly, then your uterus doesn't have that same volume to be able to contract into the pelvis. It's going to get pushed up, and then it's going to get tipped over and get lazy. Okay, it's going to start to lose that contractility and fill with blood. You're also weighing clots, weighing pads. That's a really important thing to know where we're at during the hemorrhage, to know if we are at 800 versus 2,500. That's a big difference in how we're immediately going to manage that patient.
Okay, so putting these all together, these last 2 slides, I do want you to, star them. Because this is something, one of those things that we talked about in terms of when to gather more information and when to call for help. When you're putting together an S-bar, you're going to want to have all of this information. You're going to want to know, is the fundus firm? You're going to want to know whether or not the bladder's been emptied. You're going to want to know all these things. So you're not going to keep doing something over and over if it's not working. You're going to do your vital signs. You're going to check all these things. If nothing's working and you have a good S-bar, you have all your information, you're going to stay in that room, and then you're going to get your provider. But you're not going to get your provider in that room until you have all your information. This is one of those great opportunities on these 2 slides to say to yourself, what do I need to gather? Do I have enough? Okay? We're going to have a couple of those scenarios in some of our Kahoots on whether or not you get that provider in the room or you stay there. And when I say get the provider in the room, it's really easy to do that. You can put your call bell on and say, I need somebody in here stat. You can pull something. But you're going to stay with somebody who's bleeding. Okay, just whether or not you get them in there too soon. Because one of the things they'll say to you is, okay, Samantha, what's your vital signs? And if you haven't taken one in the next, 5 minutes, then you're going to be, oh, wait, just a second. And then they'll say, has her bladder been emptied? When's the last time her bladder's been emptied? Those kinds of things, you don't want to be left hanging, not having that information for you if you've called your provider. Because if you're getting them out of bed at 2 in the morning, now for me as a nurse midwife, I'd be pretty nice, but I'd say, Audrey, I need you to go back in real quick, I'm coming. Make sure you get that vital sign, empty your bladder, do a straight cath, and let's just see if it's coming from the cervix or it's coming from a laceration or some sort of tear. Get this, and this in the room. I'm on my way. Okay, so I was usually pretty kind, but I didn't experience that all the time. No, right? So sometimes they get a little bit upset if they're getting out of bed at 2. Okay?
Get grumpy. I get grumpy. It happens. So let's talk about let's talk about what it means to do a fundal massage. All right. So we use the word massage very lightly in this context. It is not fun for people. It does not feel good. It does not feel like getting your back rubbed. It initially will feel like I am trying to grab your spine from the front, from your belly, right? So my goal is to get my hand, see that left hand, you're trying to reach up and around the fundus to grab the top of it. You're not just pushing on it, right? Like that, if you just push into someone's belly, that's not doing it. You got to get over the top of the fundus because you want to make sure that it is firm all the way down. So I'm grabbing from the top. I'm also supporting above her pubic bone because we don't want to push so hard from the top that we invert her uterus out, right? The pelvic floor is only so strong, and it's been recently had quite a workout, right, with that baby coming through. So we need to support her lower uterine segment up right above her pubic bone and push on the top. That also helps you know if her lower uterine segment is not behaving properly, right? We can have fundal relaxation, atony. We can have lower uterine segment atony. And sometimes that's the sneaky one. Sometimes that's the one that hides the hemorrhage. Because maybe her fundus feels firm up top, her lower uterine segment, maybe not so much. Maybe we got some mush going on down here, but we got contractility up here. That's because those circular muscle fibers are running different, right? They're having to do a different job. All right, initial questions on hemorrhage. Feeling okay? Okay. All right, so let's talk about lacerations. We can have lacerations in the vaginal wall. We can have them in the perineum. We'll talk about a little bit. We can have them in the cervix. That'll come a little bit later. So lacerations in the immediate postpartum, if we've just had a birth and they're coming from the vaginal wall or the perineum, are going to be bright red bleeding, right? Because that is an active wound. That's active open vessels that are bleeding. We need to fix that, okay? So if we have active bright red bleeding and our fundus is nice and firm, we've eliminated the bright red bleeding coming from the uterus, right? We know that it's coming from somewhere else. Her fundus is firm. It's clamped down, okay? So if this is something in the immediately after baby and provider is in the room still assessing, they're going to assess her perineum to see if she needs a repair, if she has a laceration, right? So at that point, they're already in the room, but maybe there's bright red bleeding from a high vaginal tear that wasn't initially noticed, right? Maybe we thought it was uterine, right? We thought it was just some extra uterine bleeding. Maybe it's vaginal. If you see that bright red bleeding and you still have a firm fundus and you just cannot figure out where it's coming from, that's when you get your provider back in the room and have them do a reassessment, okay? Let's talk about what lacerations look like, okay? The majority of women will have a first or second degree repair, okay? First degree will go through the skin and the top of the muscle. It's not going to break the muscle, okay? Second degree is going to extend through that muscle and up to the rectal sphincter, but it's not going to break that capsule, okay? So when we talk about the muscle of the perineum, it's this really cool figure 8 shape, and it creates great elasticity. So right at the perineum is where it crosses. So your muscles come down around, cross at the perineum, and go around your rectum, right? If we have now taken and had a laceration through that X, we've lost muscle tone. We've lost the ability to contract through that point, and her vaginal floor is going to be pushing down on those muscles. We need that muscle contractility. So sometimes with a first degree repair, it's much more superficial, and just naturally that repair will come back together. We don't necessarily need to put suture in it, right? Because that's actually going to be more aggravating because we need to maybe use some lidocaine and we're making that area swell and we're adding suture that can be irritating. So maybe if we're hemostatic, we're not bleeding, we're just going to leave that alone, okay? We're just going to let it heal. Second degree repairs, however, now we've entered the muscle. Now we've changed the game because now we need that muscle to come back as well as it can into the way that it was before. Okay, so that's going to be a sutured repair for sure. If we talk about getting into third and fourth degree repairs, usually as midwives, unless we've had advanced training, that we're going to be calling our OB friends in to come help us do these repairs. Okay, because these are getting deeper. They're needing more layers of closure. Okay, so this third one extends through the anal sphincter muscle. I'm watching some of the faces out front for those of you in Rochester as we've flipped through. So now we're through the rectal muscle. That's not good, right? We got to close that. We need to then close the muscle on top for her perineum, okay? If we move into a fourth degree will almost always be repaired in the operating room because this is a long repair. It's very sensitive, and she will need additional help to feel comfortable with the type of repair that we need to do, okay? So it's now extended through the rectal muscle, or through the rectal sphincter, into the wall, right? We've had tearing backwards. If we don't repair this, she will end up with things like a fistula. She will end up with leakage, right? She will have no floor left to her perineum, okay?
That separates the two.
Yes, that separates the two. So, cervical lacerations. This picture is a little bit confusing as you initially look at it. So, the two pieces that are clasping on to what looks like a clamshell, those are ring forceps. So, this is showing the cervix. Normally, when you are not in labor, looks sort of like my fist, right? Internal and external os, just like this. If we dilate, we thin it out and we open it, right? If we maybe pushed before our cervix was all the way gone, you can have tearing in that cervix because it wasn't well approximated around the baby's head. It wasn't ready to let go. Okay, so that cervix itself can tear. All right, this is also something that's going to be repaired in the OR because this is a more involved procedure. So again, if we've got that bright red bleeding that's persisting, I just can't get this bleeding to go away, but her fundus is firm, her bladder is empty, her vital signs are okay, maybe we need to just trigger that, could this be a cervical laceration, right? It's bright red, we have active vessels bleeding. And you won't necessarily see anything at her perineum. She could have a fully intact perineum, no repair needed, and she could have a cervical laceration, okay? Risk factors, precip delivery. If we're going really fast, that cervix just can't keep up. If we're doing a vacuum, we have forced the action, right? We've forced things through before they were maybe fully ready. We've got a really big baby, right? We've got a lot coming through that passageway. Talk about hematoma. Hematomas are not fun for people postpartum. They are intense and they are very painful. Okay, we've got a lot of vessels that have to stretch during the childbirth process. And sometimes those vessels rupture internally and create this hematoma. All right? So one of the biggest reasons we see hematomas is prolonged second stages of labor. So that's when we're pushing. If we're getting into the 4-hour mark and maybe we've got some swollen labia because we've been pushing so long with so much pressure down our perineum. If we've got swollen labia, we're already vasodilated. We're already at risk for that rupture. We're going to be really careful. We're going to try and minimize that swelling while we're pushing, and we're also going to be cognizant of the fact that she's at risk for a hematoma. Okay? Episiotomy. We try not to cut episiotomies unless we absolutely have to. That's true of all women's healthcare specialties now. If you do an episiotomy, you are creating a straight line, which is much harder to bring back together than a natural tear, which has overlapping fibers. So we've created this straight cut versus an overlap that we can bring back together, and an overlap that happened naturally, right? It's allowing it to break as it would versus cutting through things. Same kind of thing, vacuums, large babies, anything that's putting huge amounts of pressure on the perineum. So severe pain that is not taken away. These are not always going to be external hematomas. Sometimes you'll get a labial hematoma or a perineal that you can see, and it's really uncomfortable for people. You can also get internal hematomas. So if she's complaining of just terrible, unrelenting pain, we're maybe going to think of a hematoma. Okay? We're going to do a thorough assessment. Okay? Before we call our provider, we're going to assess. You are nurses, you assess, right? You need to know what's going on with your patient. Then you're going to notify your provider that something seems off. She's in too much pain, right? Childbirth is painful. It's a lot to take in. But she should recover to the point where she feels comfortable walking. She should recover to the point where she feels like she can lay in bed and be comfortable, right? Especially if we have a hematoma, we're maybe going to bump up into the narcotic category, okay? Typically, we can cover people with Tylenol and Motrin, okay? Postpartum, you really shouldn't need much for narcotics. Unless you've got a hematoma, then we're in a different category. So super important to educate her about what's happening with her body. Good hand washing. perineal hygiene to try and prevent that infection. Okay? We don't want that to then escalate into an abscess. So this is what an external hematoma can look like. Okay? That does not look very fun, right? That looks very painful. Like I said, you can have this immediately following birth, and it can be rapid. It can be within minutes. All of a sudden, you turned your back and you come back to her. Maybe we're going to plan to do a repair. We're getting set up. I turn back, and there's a hot dog of swollen hematoma, and she is screaming, right? It's so painful, okay? So it can also be internal. So that bottom picture is trying to depict the space that you can take up a hematoma before you notice anything external. All right, so one of the things that we talk about with problems in the postpartum period is a retained placenta. So retained placenta is over 30 minutes. It's not deciding it wants to come, all right? We give what's called gentle controlled cord traction. So on that umbilical cord, after the cord's been cut, we give some gentle traction to try and encourage that placenta to come. If it's not coming, we don't want to pull too hard because we can avulse or break that cord, and then we don't have anything to grab onto. Okay, then that placenta we have to go up inside the uterus to get it anyway. So if we are having a placenta that's stubborn, okay, we need to do a manual sweep, okay, a manual removal of that placenta. We need to take a hand up inside the uterus and sort of scrape it, quote unquote, off of the lining. Okay, walk it off. That's a better term. Walk it off.
Gently walk it off.
Gently.
You don't want to break it?
Yeah. So you're trying to keep it intact as you take it out, right? You're trying to just walk it and encourage it to let go. I want you to imagine for a second that you have just had a baby. You're trying to cuddle your baby, and now we tell you we need to take our hand and put it up inside your uterus to get the placenta off. That's a lot, okay?
Why are we doing that? Because we're preventing what?
Yeah, we are preventing hemorrhage.
Yes.
Okay, that uterus isn't going to clamp if the placenta is in there. It's just not. It's not going to clamp if there are pieces of the placenta in there. So we can have just retained fragments. So maybe the placenta has come out okay. You're assessing the placenta after delivery along with your provider, and you're looking to make sure that all the borders look like they come together squarely and they're intact. Maybe there's a chunk missing. That's a problem. That isn't something that we just say, it'll probably come out later. No, that needs to come out. Okay, that's a space for infection. That's a space for bleeding. So one of the risk factors for this, grand multiparity, lots of babies. Talked about that earlier. All right, we've had previous scars on the inside of the uterus. We've had previous scars on the outside of the uterus, right? We've created trauma to the uterus, a place where we can have extra adherence. So C-sections. Placenta previa. What is a placenta previa?
Rochester?
When the placenta covers the opening of the cervix?
Yes, good. So normally the placenta will start and adhere to the side or the top of the uterus, closer to the fundus, okay? Because we're pulling that placenta up as that baby grows, it pulls up and out of the way. With a previa, you can have it that placenta is sitting over the cervix. So we have attachment very low where the cervix is going to open. Okay, so this is not only a risk in and of itself just to have a previa, but it's also a risk that previa has implanted improperly and is going to be retained. Complete placenta previas will always be C-sections. You cannot have a baby if your placenta comes first, right? Your baby then loses all blood supply, loses all oxygen supply. So this may require that a woman have this manually removed by a DNC. So that's done in the OR, right? That's where we go up and we use tools to actually extract the placenta off the inside of the uterus. A lot of times you can get it by walking it off with a hand, okay? Not fun, okay? We are going to medicate women to help them through this process. Something that we'll do a lot is IV fentanyl. We also have nitrous oxide as an option, the laughing gas. But we're going to help medicate this experience. Okay, not fun.
And we're a little bit on a race here to get it off before it clamps down and the cervix starts to close, because we only have a certain amount of time. Because if that happens, right, then we have to go in and help dilate it again. Okay? So we're in this, that's why that 30 minutes is kind of this key thing, because then you got to act after that and figure out how to get that out.
So another thing we can have is an invasive placenta. So the placenta has decided that it wants to grow into the uterine wall, uterine muscle, a little bit farther than it's supposed to. So we can have an accreta, an increta, and a percreta. All right, so we can see in the pictures, we've got that increta where maybe that placenta has grown in just a little bit more into the layers of the uterus than it was supposed to. We've got that increta where we're getting into muscle fiber. Okay, it is solidly implanted. We've got a percreta. It's gone all the way through. It has really been overzealous. It has done all the growing. We've gone all the way through the uterus. Okay, it's possible that women will need a hysterectomy. I'm losing my words. If they have these conditions. All right, it's possible that we just cannot get that placenta off the wall of the uterus. You're always going to plan for a postpartum hemorrhage if this is a known condition. Many times this is diagnosed on ultrasound. We can see that placenta is growing into sort of a unknown area. It's sort of expanding into unknown territory. We're most likely going to have a C-section for these types of things. We're always going to plan on a hemorrhage. Uterine inversion, we talked about this for just a second on the way that we do fundal massage. You can have spontaneous uterine inversion. One of the worst inversions I had was about a year ago. We had precipitously delivering 34-week twins in triage. So baby A, as I got into the room, was coming out. I have a 34-weeker coming out. Just me, I've walked in. Whoop, okay, 34-weeker. I got one patient, now I got two patients. There's still a patient inside. Lots of patients, right? Now, whoop, okay, the midwife is coming in. We're starting to gather our staff. There comes baby 2. Okay, so we've each got a 34-weeker that we're trying to hold, and we're trying to resuscitate. Okay, 34 weeks, our lungs are maybe not quite ready to be on the outside. And then, whoop, comes a uterus. Okay, bright red, lots of bleeding. Not good. Not a good scene. That was not my favorite scene. That was a lot of bleeding. That was a scary scene. Okay? Even I get scared in certain situations knowing what I'm doing. Okay? So if you've had babies before, you've stretched and retracted, stretched and retracted, stretched, and maybe you retracted a little bit too much and lost that pelvic floor, that uterus can come all the way out. It can also happen if we're pulling too hard on the cord, and we can actually pull the uterus into an inverted state through the vagina and out. Okay? This will be a hemorrhage. Okay? The provider will most likely take a sterile glove and go through and push the uterus back up into the abdominal cavity and hold it there. Okay? Because we don't want it to come back out. Nursing management goals. Signs of a postpartum hemorrhage are detected quickly and managed effectively. We don't want to get to a massive hemorrhage. We want to prevent. We want that mom and that baby to stay together. Maybe there are 50 things going on down below with a repair and bleeding and massage. That woman can still focus on her baby. That family can still stay up here. Because when we have connection, the mom-baby connection, we have oxytocin release. Her body wants to live. She is a mother. Innately, she wants to live, right? Postpartum hemorrhage kills. Yes, it does. Absolutely. Innately, her body wants to save herself. She wants to be around to raise her children. So we keep that mom with that baby as long as possible. Okay? She needs to be able to know what's normal and what's abnormal when she goes home, right? If she gets home and she's 3 days into being home and she's starting to pass, maybe a baseball-sized clot comes out, she needs to know that that's abnormal. She needs to know that that's something that she should call for. When she goes home from the hospital, she should be at the level of a heavy period, right? She should not be having clots, and her bleeding should successively get better. If she notices that maybe one day she does 4 sets of stairs and 2 loads of laundry 2 weeks after having a baby and she has all this bleeding all of a sudden, we need to make sure that she knows That's your body telling you to slow down. Take a breath. You have to heal. But if you're having clots and bleeding and you really haven't changed anything, maybe we need to think about the fact that there could be something left. There could be atony that's happening. So that atony that can happen when she goes home, late postpartum hemorrhage. So if we're past 24 hours, up to 6 weeks, we're having a late postpartum hemorrhage. That uterus has not come all the way back down. It has not gotten into her pelvis, into a subinvolution. Maybe there's infection. Maybe there's parts left behind. Okay? That placental site isn't healing properly. We're going to have lochia rubra, which is your initial bleeding, bright red. It's called lochia when it's in the postpartum period, longer than 2 weeks. If she's not starting to see those changes toward more of a serosa, then we have a problem. She's still bright red bleeding at 2 weeks, abnormal. If her lochia has a foul odor, right, if she's noticing that things just don't quite feel right down there, she has a fever, right? These are the women that are maybe going to try some at-home Methergine. She's going to take some PO Methergine for a while, see if that can solve things. She might go on antibiotics if she's febrile and has an infection. She also may need to come back and go in for a D&C to help clean out and help heal that area of the uterus so it can function and clamp down.
I'll leave it on time. It's been an hour and a half.
I know. Are you guys doing okay? Do you need a break?
How many do you have?
Rochester?
Yeah, break. Okay. Let's take a 15.
Okay, we'll take a 15-minute break.
That gives you enough time to get coffee and everything.
Yeah. I was getting tired. That's okay.
I'm calling to do a little update. Little things that I'm coming with him. I don't need it. Ready to okay, we can go. Because I don't know. Yeah. get started. I'm going to let Audrey go home and go to bed. Say thanks. Thanks for coming. Is everybody ready in Rochester? Hi, Corey. Thank you for letting me know. Hi, Bob. All right, so we're going to finish up this, and then we're going to move on to Megan's lectures on newborns. Okay. So when you think about an infection, right, you got to think about a couple different things. And when we started learning about this was actually something that was being followed more and more because normal, healthy people were actually dying of infections in the postpartum period. And so when that was happening, they thought, well, we need to get a hold of this. So they had this Joint Commission sort of law, or I would say almost like sentinel event alert, but it became law that we were going to really look at this and we're going to take good care of our women who were going home very quickly, so delivering at homes, right, and within the home setting, and we're going to have them seen quicker. We're not going to let it sit for as long, okay? There are diagnostic criteria, though, that we have to follow on this, and that's going to be a temperature greater than 100.4, okay? And then occurring on any 2 of the first 10 postpartum days, okay? And then exclusive of that first 24 hours. Why? Can anybody think why possibly she might have a low-grade temp at 100.4 or so in the first 24 hours? Rochester?
Dehydration.
Yeah, dehydration could be an indicator of that. What else? What other pain modality could cause a slight increase in temperature? Anybody think about one? I haven't learned a ton about them yet. Epidurals. When we used to do long inductions, we used to see this a lot more. Okay. The other thing is remember when you think about what the state of alert the body is in when they are pregnant, that white blood count is going to be high. Most of us sit between 7 and 10, right? 1,000, but sometimes you'll see a pregnant person up into the 22, 24, 25. They might even get a little bit higher right after birth. And that's because that whole mechanism, birth itself, creates this incredible response for the body to start fighting off a bunch of different things. So we just give it 24 hours, we let everything settle, and then we start watching this. Now, if a woman is breastfeeding, we're going to look closer to mastitis possibly. Pretty rare that you get mastitis really in that first 10 days. It usually will happen maybe at 2 weeks, maybe a little bit further, with engorgement and different things like that. You can get it, but we're going to watch this real closely for those different types of things. So you have to make sure that you document this. If you're doing vital signs and you have someone that is going home with a low-grade temp, maybe sitting at that 99, 100, 100.2, you're going to give her all the warning signs for infection anyway, and you're going to have her watch this very closely. Make sure she has a good temperature, a way to take a temperature at home. How many of you actually have a way to take a temperature where you're currently at? Everybody got a thermometer? Not many. So, right? This is the same thing with a lot of households. It's funny. I used to have tons of them. I don't have good working ones either. I just realized one of my kids. So always have a good one on hand that works. Those battery operated ones are good as well. When you think about incidence, it doesn't happen all that often, but when it does, because it becomes systemic, the uterus is a major organ, the infection goes all the way through the body, and it can be quite detrimental to them, right? And people can actually lose their lives. So that's why we're watching this closely. Okay? Obviously, it's going to be a little bit higher in your C-section patients because they've had major surgery. Okay, so you'll see that higher. What are the types of infections? Well, you can get endometritis within about 3 to 7 days after birth. That's the endometrium lining where that uterus, right, sits in terms of the inside of the uterus where the placenta will attach. So that'll be where that's going to happen. If you've got it in the uterus, it'll be a sawtooth pattern. So it'll be very consistent with something like a virus, right, that's going on where sometimes you'll have a temperature late at night, but you won't have it in the morning. Well, with this type of infection, you'll have that kind of up and down. You'll feel great, and then all of a sudden you'll kick back in. You'll have the sweats, a high fever, and then it'll break and then back down, okay? So sometimes hard for people to really know, do I have an infection or not? Then you think about the bladder, okay? In the birth setting, It is not one of those cases where we do what's called CODI, where we actually want to place a long-term catheter in for too long, right? And if I understand it correctly, and you've been on the unit a little bit sooner than I have, but do they just do straight cast, or are they going to put in a catheter long-term for those with epidurals? Is it still timing of it? Timing of when we get it? Okay, within 6 hours still, or?
So it totally depends. Like, is the woman 3 centimeters, and this is going to be a 24-hour epidural? And then with C-sections, they always get one for the first 24 hours. But they are moving more towards straight catheters versus Foley. And why is that? Infection rates, yeah.
And we used to think like when you do a straight cath, which is what we call a morphine, and the infection can travel a lot faster, mainly because of the vascularity that's present. Okay? All right, so you might see them go from bladder infection to kidney infection. And sometimes the signs and symptoms are vague, not as normal what we would experience, like low backache, right or left side, those kinds of things. Okay? And then you have surgical infections from the wounds. So you can have a superficial wound infection, which would be from just like the scar of the, or the incision of the uterus. That's a superficial. Those can be pretty nasty. You want to get on top of those pretty quickly, because if they get any further from the superficial and go any deeper, right, you're going to be opening that up, and you're going to be packing it. You're going to be putting a drain in there, okay? So for our women that have a large penis, that are obese, we have different ways that we kind of try to keep that up and dry that area out so that they don't get these superficial infections, all right? You need to get it in the perineal laceration, which is not very comfortable as well. Remember, it's a clean area. When we have a laceration, it's not like I clean it really well and I will be applying different types of things to get it really clean. I will be repairing it. So we don't necessarily introduce a ton of ways to clean that whole area off, because for the mom, it's a clean area, right? It's not a sterile area. The vagina cannot be sterile, okay? So we're going to watch that really closely. Most women can really fight off most infections, even in that area. We're going to keep it nice and dry as best we can, and we're going to use a peri bottle to wash that area off in order to do that, okay? For those patients that have a cesarean section, they're going to get a 2-gram load of an antibiotic, okay? That's just going to be covering them for any possible infections during that surgery, right? Does that make sense? You're going to be doing RETA, right? You're going to be looking at this incision. You're going to be looking at how well approximated it is. What does it look like? Is it swollen? Now, the first 24 hours is amazingly different than the next, 24 hours on a perineum. So if someone has a large repair and she's been pushing a long time, the swelling is quite intense, okay? That whole area can just look very distorted. But within 40 hours, after 24 hours, it looks pretty good, it's pretty amazing. And as nurses, you might be able to see that, you even see it change on your shift a little bit. You can have ice packs, you can do different things, and definitely make sure that they clean that area, use sitz baths, different things like that can relieve that pain and get that swelling to come down. Okay. This is just a great slide just to kind of show you the risk factors and sort of the reasons to that. I won't go through it. You guys can read it. Okay? Just a summary slide. What do you do, right? I just talked about it. You're going to look for increasing fever that's lasting, that's not going away. You look for that sawtooth pattern, any pain, right? When you have an infection, usually you've got pain, okay? And then you'll be doing that RETA, like I said, and documenting that, and then any culture results, right, from that area, or possibly even systemic, some blood cultures to see if that is a systemic infection. So you'll be giving antibiotics, you'll be managing her pain. And just a reminder, as nurses, one of our big key objectives is that people that come in and that are assessed and are having pain, that within an hour we relieve their pain, okay? And that we re-look at this and say, have we done this and how well we done that? Okay, so that's a Joint Commission measure and something that we watch real close. Yeah.
I have a question about the fever. So it says for the definition of postpartum infection would be temperature of 38 degrees or above taken by mouth 4 times a day. But with this sawtooth pattern, does that mean that if you get like one reading of 100.4 of like the 4 measurements you take, or like do 4 measurements have to be above 100.4?
Most likely we're going to take a couple of them, right? We're going to take a couple of them. Within about a day to 2 days, you're going to know if you've got a systemic infection. You'll kind of see that, right? It's a classic sign. It's a classic sign. One of the things we do before they leave is we talk to them about signs and symptoms of infection on their warning signs or danger signs list before they leave. You all will be able to do some of that education for those patients that you help discharge. So you'll see that list, okay? And remember, when you give discharge instructions, that's a plural statement. You're not going to just be telling them, okay, all I have for you is just watch out for a temperature greater than 100.4, right? It's going to be a series of things. That's a really important designation, okay? When you give discharge instructions, it's a series of different things. All right, when you think about people that have thromboembolic diseases, you're going to think about a couple different states. One is you're going to think about the hypercoagulability of the blood, that is this phenomenon that we have after birth. We've got 50% extra blood volume, and we got to get rid of it, and only a little bit has left us via the birth. So what has to happen? It's got to be absorbed, right? Well, the best way to do that is to move around and to have that woman do that. But does she move around right after birth very much? A lot of them don't, okay? We don't want that, especially right after a C-section. So you will see them get what's called a CD or whatever, a device that's going to actually pump their blood back and forth. Okay, that'll be given to them for the first 8 hours right after birth, right? SCDs
For C-sections.
Yes, for C-sections. For vaginal births, not so much. We're going to expect them to get up and to move around. Just in that, walking down the hallway, going to get some snacks, do some different things, that's going to help with that and moving that. We just don't want it to be static in the extremities, which is where it's going to collect. All right? So we want to make sure that we watch for that. Now, some people just have disease, right? They already have this process in place, and they're already at a higher risk. We are going to know about these people beforehand, and we're going to watch them real closely, okay? Anybody that's not been on any sort of blood thinners or anything like that while they've been pregnant, right? That's going to be something we're going to be watching for as well. And we know that they've already got something going on. Right? There are two different types. You're going to get a superficial vein thrombosis, which is most likely what we're going to see more often. This is when just you can have that just because of the result of pregnancy. Okay, this doesn't necessarily mean you got anything really going on. Or you get these deep vein thrombosis, right? And those are the ones that are more common with somebody who has a history of thrombosis, right? And then you can get something that's called septic pelvic thrombophlebitis, which is an infection of that area as well. And they can become septic from that. Okay? And lastly, the last one that's really truly the most concerning here is a pulmonary embolus. Okay? Or what they call an amniotic fluid embolism as well. You can get two different types. And the amniotic fluid embolus can happen during birth or right thereafter. And that's just the mixing of those two, the fluid and the blood, and it travels up. Okay, but the pulmonary embolism is when you've got a little DVT and it gets dislodged and it travels up. All right. Can anybody tell me any signs and symptoms of somebody that's having a pulmonary embolus that you would be watching for postpartum? Or anybody? Go ahead.
Maybe with a low oxygen saturation.
Possibly. What goes with that? If you have a low oxygen saturation, what are you needing?
Need more oxygen, so they're going to be breathing like
Right.
higher respiration.
Are they going to want to be laying flat? No. Are they going to be wanting? They're going to be in that state of like, I can't breathe, and then they start feeling panicky. Okay. All those people that have this happen, you know it right away. They start looking around for anybody that's going to help them. They start to feel the panic of what's happening. Okay. You don't have a ton of time, but you can watch for it and you can help them. Some people, the survival rate is pretty good if we can see where it is. Start to use mechanisms to dissolve the clot. Okay? And some people it's not. What are the risk factors? They're going to be pretty similar to most of our risk factors. The age, in terms of age, the older population will have more risk for this. If you've had multiple babies, okay, or multiple pregnancies and births, I should say, you already got a history of it. If it's inherited. Okay, factor V Leiden is an inherited disease that most of us will know about. You got varicose veins, that puts you at a higher risk. That vascularity is already traumatized, so that would be an issue where you've got lots of twists and turns, and that blood in the additional amount can become static and then start to clot in that area because you don't have the good blood volume or blood flow, okay, naturally. A trauma area where you get a lot of bruising, that can cause that. Anemia. You're just inactive, like we said. C-section just puts you at a higher risk, mainly because you don't really want to get out of bed. if you're obese as well. And then, of course, diabetes and smoking. Smoking being probably one of the number one issues with this. Okay, we all know that with the birth control pill too as well. That if you're taking the birth control pill and you got some of these risk factors, you're not going to want to mess around with this at all. Okay? Any questions on those? All right, so this is kind of what it looks like. Okay, with an SVT, right? It's a little bit more superficial. You can see that there. Swelling and redness, tenderness will be present. It'll be very warm and it'll be unilateral. Okay, you're going to be be watching that closely to see if it changes. And when you look at a DVT, right? You look at those extremities, right? You'll have pedal edema. You'll have decrease in pedal pulses, and you'll have a positive Homan sign, okay, which is pain most likely. Now, are we doing Homan signs? Not really. We teach this only because it's one of those ways that we can determine, but it's like if you have pain there, we're going to keep doing that and keep eliciting that pain response and possibly the risk of dislodging that. Okay? All right, so we have got one and then one plus all the other symptoms. Any questions on that? What do? Well, you're going to assess for risk factors. You're going to try to determine this. I would say that all women, irregardless of anything other than being pregnant and having 50% of blood volume, are at risk, right? They're already at risk for this. Pregnancy is the biggest risk factor, right? So you're going to do everything you can to mitigate that risk. In terms of a C-section, somebody who has a surgery that's less than 30 minutes doesn't necessarily need to get these devices on their legs. But a cesarean section, they can be done in less than 30 minutes, but most often they're a little bit more than that. So we, as a general rule, will put these on these women because we know that they're going to be at least static for 4 to 6 hours. But we're going to try to get them up very, very quickly. And so you're going to see fresh C-sections having major abdominal surgery getting up very quickly. And we have some good drugs that helps them with that, but that's a key thing mainly for this reason. Okay, let's follow real closely. Okay? And they're going to love these devices because it just feels good and it's comfy in there, but you're going to have to take them off and get them up. Okay? And they're not going to love you for that. All right, so if you see any of this, you are concerned about it. I had a couple clinical groups. I had one semester, one the next that actually were worried about this. And we did an ultrasound, and one of them we found it, and one we did not. We went through all the different steps to it. So it was really cool, and a nursing student found it. And other people had been assessing her legs or been documenting that they were assessing their legs and never found it. That was pretty cool. Okay, so you guys have these great skills. So you're going to be looking for that. Okay. You can do a bunch of different things to alleviate it. Most often, we're going to be following the strict protocol put forth by our providers. Okay. Right? And if you have one and you have it documented in one pregnancy, it's going to be well known in all your subsequent births. We're going to be watching you real closely. Okay. We might do some additional tests too, see if you've got any of the hereditary inherited diseases. There we go. Okay. You're going to be put on an anticoagulant, okay? Heparin or sub-Q Lovenox in order to dissolve it. Okay. And then, of course, you're going to have the anticoagulation studies that will follow that just to make sure that we have a good ratio and that we're not at too high of a level, right? Different ways to educate around this so that you can educate people. Even long term, when you think about SVTs, not crossing your legs. How many people cross their legs all the time? It's something I do all the time. Okay? I cross my legs. That's a comfortable place for me. My legs down on the floor and sitting straight up is not. Regular exercise, drinking fluid. One of the things I always say here is, when you're drinking fluid, even as nursing students, and then when you become nurses, when you go to the bathroom, how many of you notice that your urine's always clear? Is it clear all the time? How many people have clear urine? 100%.
Yeah, I believe
All right, well,
Raise it proudly, people. There's nothing to be.
and if you don't, how many of you don't have clear urine, right? No, if you don't, you're not hydrated. It's the number one way to see if you're hydrated. So clear urine means you're hydrated. Any sort of yellow in your urine is not unless you're taking a vitamin that causes the urine to be yellow. All right, so most people will say to me, oh no, I drink plenty of water. I drink plenty of water. I'm like, well, okay. And then they'll hand me a urine sample and, it's like, rusty colored, right? That's not enough fluid, all right? Not enough fluid. And we're all guilty of it, especially when it's cold. A lot of people don't want to drink water. Yeah, they want to drink something hot. Okay? We're going to encourage everybody to stop smoking. That's a pretty hard thing to do, right? Just because of this, but we're going to encourage it. Okay? On top of the things that we do for a superficial vein thrombosis, we're going to do for a DVT. Don't rub it. Decrease alcohol intake. Bed rest. And then we're actually going to say to avoid pregnancy. Okay, subsequent pregnancy for a while till we figure out and we can get this fixed. Okay, that way another pregnancy would not be good for this. All right, so we would highly encourage birth control in this case. All right, that ends this presentation. Yay. As we switch over, we'll bring Megan up. And you know, a lot of these students do know you, but about half of them don't, or a little bit more. So they had you in 3802 when you were doing your practicum.
So my name is Megan. For those of you that are in Rochester, none of you have met me. I am a doctorate of nursing practice student in the nurse midwifery specialty. I'm in my third of 3 years. I have been a TA for this class twice, so 2 semesters, and then I was a clinical instructor for 2.5 years. I have worked as a labor and delivery nurse for 3 years. 2 years of that was in a high acuity tertiary unit, and now I'm a casual nurse at a rural hospital, which has its own interesting things that go along with that.
And how did you come to nursing?
How did I come to nursing? So I am a second degree nurse. My bachelor's is actually in sociology, and I taught sex ed in high schools in the Twin Cities for 3 years before I came to nursing, and I did the Master's of Nursing program here at the U. So I have some teaching experience. I really enjoy teaching in classrooms, and I really enjoy working with you guys quite a bit. Can you hear me okay?
This is your first semester where you're not actually in clinical or something. It's a big deal.
It's a big deal. Not teaching. My life doesn't feel complete. All right. So we're going to do the newborn complications today. You hopefully watched the voice threads that. Do you have a question? What's going on in Rochester?
Oh, we just got here. I can't hear him.
You guys can hear me?
I think you're speaking a little low, so you're going to
If you could speak up a little bit better.
Okay. Better?
Yes,
Okay.
thank you.
All right, so we're going to do newborn complications. Hopefully you all watched the voice threads. Usually when I ask how that goes, I get some pushback. I understand that you're busy and that asking you to do work before you come to class is really annoying, right? However, I think that it can be really beneficial to have those to rewatch. And then I think that there's just so much information in this class to cover that we simply can't do it in 4 hours a week. And for those of you that are thinking about going into women's health or NICU or peds, this is really important stuff that you're going to see in practice. Yeah.
I was just wondering if there's any way to upload the actual presentations from the voice threads. Or not.
Well, it depends if they're still saved on my computer. So let me take a look, and then I can post those for you. Anything else? Okay. So, it's been a little bit. We'll see what this bad boy is.
There's no such thing as a perfect writer. This is why I use Grammarly to check my name.
Oh, I just really enjoy this video. We're just going to watch it because it cracks me up. Dr. Summers has seen this like 3 times. It gets me every time.
Oh my gosh.
You can imagine what they're saying.
I mean, you can pretty much imagine.
I'll go with
Can you just imagine watching your partner do this out your window? I think I'd pee my pants. Alright, I really love animals. If you watch the voice side, you probably find the million. Okay. So, we're gonna switch lanes here. We're gonna go into newborn hypoglycemia. Okay? So newborns are these really weird, strange creatures, and they kind of are in a class all of their own, where they don't fit into quite peds, and they definitely don't fit into adults. So things that we talk about here are really only applicable to that population, and the newborn period is from birth until 28 days. As midwives, we are actually able to care for newborns up until their 28th day, which is terrifying for me. All right. So the objectives of the hypoglycemia, what I want you guys to take away is to be able to identify risk factors, understand signs and symptoms, and then know the nursing interventions for a newborn that has hypoglycemia. So the definition is going to vary by the facility that you're in. Cranmer defines neonatal hypoglycemia as less than 30 milligrams for the first 24 hours of life. So most facilities that I have been in, if you have a newborn that's at risk for hypoglycemia, you're going to take blood sugar within the first 2 hours, usually after you've initiated feeding. And if it is below 35 that first time, then you have a hypoglycemia. If it's above 35 within those first 2 hours, you're safe. Now when you take it again, it has to, then it kind of increases incrementally. So eventually you want the newborn within the first 24 hours to be above 55. Okay? What happens if you saw 55 on an adult? Would anyone cry? Yeah, be a little concerned, right? You're like, okay, this person might die. 30 on a newborn, 35 on a newborn, they kind of look normal, right? They're not showing the signs and symptoms that an adult would. And what is your lab going to do if they see a hypoglycemia or result that's 35? They're going to call you and be like, you have a critical result at 35. And if you don't know that that's normal for a newborn, you're going to be like, oh my gosh, my world is ending, right? So you have to know that the lab doesn't necessarily understand that this is a newborn, but that's going to be different. Okay? Kind of going into a little bit to the pathophysiology of hypoglycemia, or the physiology of hypoglycemia. The placenta produces hormones, estrogen, cortisol, human placental lactogen. These hormones inhibit the functioning of insulin, which is why you're at an increased risk of gestational diabetes during pregnancy. And then the blood glucose level is increased. And why do you think that that is? Why does your body naturally do that when you're pregnant? More energy for who?
Or say it loud so they can hear.
One student said more energy. Who needs that energy?
The baby.
Yeah, the parasite that you're growing, right? You got to be able to support that thing. And so that newborn needs a lot of things, but one of them, or the fetus needs a lot of things, but one of them is going to be blood sugar. And so your body is awesome, and it knows that you need that to sustain a pregnancy and a fetus, and so it automatically adjusts to make more blood sugar available for that fetus. Now, all of a sudden, you give birth, and the placenta comes out, and all of a sudden, your body goes back. You guys kind of talked about that. For a newborn, what is kind of happening in that process for them? Do you think they have insulin during that period of time? Or if they do you think it's the same as an adult? No, because they need that sugar to grow, right? You are growing from a teeny tiny little cell all the way to potentially 13-pound baby. You need all that blood sugar that you can get. And so their insulin is very different from that of even a child. So causes of neonatal hypoglycemia. So deficient glycogen stores. So if they're premature, small for gestational age, or are not feeding or poorly feeding. So what does the SGA mean? Small for gestational age. Yeah. And is that different than IUGR? And what does IUGR mean? Yep. Intrauterine growth restriction. I heard some Rochester people murmuring that. And they are different. And the biggest difference between SGA and IUGR is that IUGR is always pathological. Okay? So if you are a pregnant lady that has a hypertensive disorder, your infant's more likely to be growth restricted. And when you think about that process, it makes a lot of sense, right? Your vessels are highly inflamed. The blood is not perfusing to the placenta like it should. That infant is not getting the nutrients it needs. So IUGR babies, SGA babies, and then premature babies are at risk for hypoglycemia. Infants of diabetic mothers, regardless of the type of diabetes, are at risk. Okay? And that's because, anyone have a guess? Yeah.
Is it because they have to produce more insulin while they're...
Yeah.
And then
So, yeah. You come out, right? You're used to a certain level of blood sugar in utero, which for diabetic women is often higher. And then you come out, you're cut the cord of life, and you're like trying to do this on your own, and all of a sudden you're like, oh my gosh. And so your pancreas makes a ton of insulin because it's used to a certain level. Okay? But all of a sudden you don't have the same amount that you did in utero. So those babies actually have too much insulin on the outside and not enough blood sugar. Congenital metabolic deficiencies. Those are not super common. I don't know a lot about them, but that's certainly something that you're thinking about if you have an infant that is consistently hypoglycemic. Okay, so who can tell me who is at risk? Not looking at the screen. Who's at risk? Who would you think about? You are a nurse. Little babies? Would you worry about fat babies?
Yeah.
Why? Kind of the same as like the infants of diabetic. They have all this insulin that they're able to produce and not enough blood sugar coming in. Also, they were in utero and they didn't have to do a lot of work. They really didn't have to do anything to get their food. Now they're on the outside. What do they have to do to get their food? Work really hard. Breastfeeding is really challenging. So they have to put in and expend a lot of calories to get that nutrition out. All right, so we kind of talked about this. One that we didn't talk about is a 5-minute Apgar score of less than 7. So what is that? What does the Apgar score mean, and why do you think that applies here? What is the Apgar score?
Kind of a gauge of how well the baby is adjusting to being alive.
Yeah, yep. How well they're adjusting to this whole new, cold, loud world that they've just entered. And a 5-minute Apgar score of less than 7 is an Apgar score that is concerning. That means that that infant has not transitioned well. That infant is likely and should be in either a special care nursery or a NICU, and often has traumatic birth, right? For some reason or another, they haven't had a traumatic birth. When you have trauma, what do you need more of to heal? Right? Everything, right? Nutrition. So a lot of these babies that are in special care nursery or that are in the NICU, well, one of the first things that they get after they're stable is a feeding tube, and that's to make sure that their blood sugar is up, and those babies are getting watched very closely. Another thing is terbutaline, and does anyone know what terbutaline is? Have you talked about it already? Okay.
A little bit. They got it a little bit last week.
Okay. So terbutaline is a medication that we'll use to stop premature labor. So it's a smooth muscle relaxant, and one of the ways that it works is it increases your heart rate, and if it increases your heart rate, what else does it probably increase? Your metabolism. And then it also, through processes that I don't quite understand, increases your blood sugar, decreases your blood sugar. And so women that are diabetic and then newborns, you need to watch really carefully because they will often become hypoglycemic. And then betamethasone, how does that work in adults with a steroid? What does that do to your blood sugar? Well, none of you are answering, so let me just tell you.
Speak up.
Okay, can you hear me? Thumbs up, Rochester, thumbs down. Okay. Are you interested in this? Thumbs up. None of you put your thumb up. Do you see one? All right, I'm good. Hypoglycemia, signs and symptoms. So you can see from this baby, what are some things just looking at this picture that you're like, that doesn't look right?
Discoloration.
Discoloration where?
Around their mouth.
Around their mouth, right? So central cyanosis. Temperature instability, so you guys will, as part of your clinicals, once you finally get to do them, we'll be taking axillary temperatures on newborns. And it's really, really important because that is one of the first signs of hypoglycemia. So if you have a baby that's cold you want to rewarm it, and then in about half an hour, you're going to retake that temperature. And if it's still cold, you want to be thinking about taking a blood sugar. Jitteriness. So jitteriness is kind of, they'll shake, and babies can't do that to warm up. So if they're shaking, it's usually a blood sugar issue. It can also be that their central nervous system is not quite developed yet. So sometimes I'll have moms be like, my baby's shaking, they must be cold. And how would you respond to that? Can babies shiver to warm themselves up? Are they able to maintain their own temperature? No. So this is an educational opportunity where, okay, well, I feel confident that your baby's blood sugar is okay. We just checked it. So it's probably some neurologic instability, but you always want to make sure that you're ruling that out. Low tone. What do I mean by that? What does low tone on a newborn mean? So the scariest times that I've ever walked in on a newborn is when they're just like laying there, right? So they're not, like a lot of newborns, if you guys have seen them or you will see them, they keep their limbs really close to them. There's like a lot of tension. So if you pick it up, they'll pull it back close. Newborns that are floppy, that's concerning. If they're not feeding well, we're concerned for a couple reasons. If you don't have a lot of energy, you're not able to sustain a good breastfeeding session, but also you're not getting those nutrients. So that kind of is a double-edged sword there. And then anytime that they're apneic. So nursing interventions, breastfeeding, okay, is one of the hardest parts about being postpartum, especially for first-time moms. Not only do you have to figure out what you're doing, but so does this newborn wobbly thing, okay? So getting help and making sure that you know how to help women breastfeed is really important. Check blood sugar within 1 hour of birth. Most facilities are moving more towards 2 hours of birth, just because we know that it can take a while to initiate breastfeeding. If you have a significant repair, you're probably not going to be able to start breastfeeding while you're being repaired, or if you have a hemorrhage, something like that. So there's like a grace period there, but making sure that you're checking after the first feeding. Any results that are less than protocol, you're going to send a serum glucose to the lab. Once again, anticipate that you're going to get a critical alert if it's less than what an adult would be. And then help with breastfeeding, provide donor breast milk, and who knows what donor breast milk is? Most of you should have that in your sites and should know how to talk about that. So donor breast milk is someone who is breastfeeding, and they're super producer, so they have a lot. So they'll send it to a breast milk bank, and then they'll pasteurize it. So it loses a lot of its, like, some of its benefits, like antibodies, because those can't sustain that high heat, but it's still better fit for a newborn's digestive system than formula. So that's always your first choice if you're going to go to supplementation. And then, obviously, formula. And then you're going to recheck blood sugar within a half an hour of the flow. Any questions about that segment? Okay. Newborn jaundice. So these are kind of tied. You're gonna see kind of a central theme here, and blood sugar, jaundice, they're tied to breastfeeding. So I want you to be able to read these objectives. Hopefully you can read the objectives, and then hopefully I'm meeting them. Let me know if I'm not. So definition of jaundice is elevated bilirubin due to breakdown of erythrocytes. Physiologic, so it's happening after 24 hours, and it's the breakdown of fetal erythrocytes. Okay, they have a shorter lifespan. Hepatic functioning is not up to par, they're not able to keep up with the high demand, and there's a higher incidence in breastfeeding infants and preterm infants than there is in formula feeding infants. Who thinks that they might know why a breastfeeding infant versus a formula-fed infant might have a higher risk of jaundice? All right, even if you're not saying it, are you at least thinking about it? Okay. So who can kind of walk me through how you get rid of bilirubin? How do you excrete it? Did you say it? Right? So the color of your feces, that is a direct result of bilirubin excretion. And so who do you think poops more? Formula-fed baby or a breastfed baby? Formula-fed, because there's significantly more volume, right? So formula-fed babies are a lot less likely to have jaundice because they have that volume. They are able to kind of pass that through. breastfed babies have a lot smaller volume. It's a lot more nutrient dense, but they're a lot less likely to have bowel movements at the same frequency as a formula-fed infant. Preterm infants, their hepatic functioning is just even less up to par than a full-term infant. So any baby that's born preterm has some significant barriers usually to face. Unless they're 36 weeks, generally they do a little bit better, but even then they can still have some stuff. Pathologic jaundice is happening within the first 24 hours. And that 24-hour window is when those cells kind of start changing, and so that's when you kind of anticipate that it's going to be physiologic versus pathologic. It happens with blood incompatibilities and genetic abnormalities. So what blood incompatibility are you thinking about here? Anyone? RH incompatibility. Is there any other one that you might know about?
Sounds like Rochester students.
What did you guys say? Rochester. ABO. You guys heard about that or read about it? It's not as significant as RH, so we don't talk about it as much. But if you are an O mom and you have an A or a B baby, that baby is a little bit more likely to be jaundiced. It's certainly not as significant or as detrimental as an RH incompatibility. All right, so for physiologic jaundice, risk factors are early or late preterm gestational age. So what is the difference between an early and a late preterm infant? It's the gestational age at which they were born, and I think the cutoff is 32 weeks is like a late preterm, but like really preterm at 36 is very different than a 32-weeker. Birth trauma. So if there was a really bad fetal heart rate tracing that indicated like acidosis, right? If there was a shoulder dystocia where that baby got stuck. Have we talked about that yet?
Not yet.
Not yet? Okay. So talk a little bit more about that. Sometimes even breech. So anything that might cause stress to that newborn is going to increase metabolism, right? Poor feeding, right? So if they're not able to get in those nutrients, they're not going to be as stable as an infant that could. RH incompatibility, ABO incompatibility, and then exclusive breastfeeding. The more we learn about breastfeeding and the more we begin to understand breastfeeding medicine, the more we realize that those infants tend to lose more weight and they tend to be more at risk for jaundice, but it actually tends to be okay. So given the option between formula feeding and breastfeeding, we're always going to choose breastfeeding as long as that woman is able to.
It's once that fluid volume comes up a little bit, because colostrum doesn't have a ton of fluid, but it's packed with nutrients, then the milk comes in and then they get a lot more fluid and they can start clearing that out of the liver. Remember, you need food, absolutely need food in the stomach to metabolize and get rid of all this waste through meconium. So that's why we used to just feed them water, and nobody could understand why, I thought it was just volume that would get rid of jaundice, but it's not true. It's actually food has to be in the system, go through the stomach, and then go through the bowel to eliminate it. Make sense? So that's a key thing. You cannot just give water for this to remedy itself.
So yeah, should you ever give a newborn water? When can you introduce anything besides milk? 6 months. Yeah. So an interesting article that I read recently is that they believe that physiologic jaundice is actually protective against sepsis. We'll talk a little bit more about that, but I think that's really important to think about, is that maybe our bodies do these things for a reason. And in a low-risk, healthy woman with a low-risk, healthy infant, that jaundice is actually there for a reason, and it's protective. So I think you guys, over the course of your career, will see more of that kind of research coming out. Also, I love this photo, and it's a Gap advertisement. So it's normalizing breastfeeding. Okay, many of you have never seen a woman breastfeed in public, and I think seeing an ad like that makes it more normal. So why?
Question here.
Yeah. Hey.
Hi. So is RH incompatibility and ABO incompatibility for physiologic jaundice too?
No, I think I think it's mostly pathologic because it's happening within the first 24 hours. And so that's what I would focus on. I wouldn't call that physiologic jaundice, although like when you think about it as a physiological process, but we're more concerned about that because it's often more severe and happens sooner.
So is this why then for risk factors for both physiologic and pathologic?
Yes.
I think just the word physiologic that was throwing.
I will change that for the next time.
Okay, thank you.
So why is this so important? Jaundice that is untreated can lead to kernicterus. That's almost entirely preventable in physiologic birth. And you can see here from this picture that kind of like brighter spot, that's kernicterus. And so that's when the bilirubin byproducts actually stay in the brain, okay? And people that have kernicterus can have permanent brain damage, including cognitive impairment. So nursing interventions for jaundice include providing education about prevention. So as a postpartum nurse and as a labor and delivery nurse, you are going to be talking to your patients about the importance of frequency of breastfeeding, and how to know that your infant is hungry, how to know that they're satisfied, all those kinds of things. You're going to be taking a TCB, and that's what that little machine is. And it's a transcutaneous bilirubin. And it's just kind of reading the level of jaundice. You put it in this fun little website, and it tells you if you're low risk, medium risk, or high intermediate risk, or high risk. Infants that are at certain levels will be kept in the hospital until their levels are down. So provide education about BiliLights. Oftentimes a pediatrician will prescribe a BiliLight, and then you're the one that's going to teach the parent how to use them. Okay? Questions about that section? All right, respiratory distress syndrome, or RDS. What do you know about this? Nothing? Everything? Some things? All right. Why is this baby in that weird position? Anybody know? What happens to babies that only ever lay on their backs? They get flatheads, right? Can babies get bed sores? Yeah. And this, it looks like maybe is a little preterm. Preterm babies, their skin isn't the same as a full-term baby, and they're more susceptible to skin breakdown. So if you work in a NICU, you're going to see babies be in these weird, funky positions. And that's to help prevent, their head from molding into one spot, help prevent pressure ulcers or skin breakdown. Also, how do you think a baby looked in the uterus? Kind of like that, right? They're hanging upside down for a really long time with their butts up in the air, and I bet that feels really good and comforting. So common causes of respiratory distress in newborns are immature lungs, so less than 37 weeks gestation, and what do you get to help prevent this? What is it? Betamethasone, yep. Amniotic fluid aspiration. So theoretically, in the optimal type of birth, an infant comes out of the vaginal canal, and that vaginal canal is so tight, it is literally squeezing the amniotic fluid out of their lungs. How cool is that? How cool is that? Now, any fluid that it doesn't get out, when you take that first deep breath and you cry, often you're going to see kind of little bubbles, you might hear them sound a little gunky. They're able to expel that fluid, or their lungs are able to absorb it. Okay? If that doesn't happen and they have too much amniotic fluid in their lungs, it can lead to RDS. A pneumothorax, which is what this picture is of. Meconium aspiration. So we don't worry about meconium aspiration as much as we used to. Anytime a baby has meconium, we always call in our NICU team or your special care team. You want to make sure someone's there that could intubate them if they need to. What is meconium aspiration, and why do you think it matters? What is meconium? Baby poop. Yeah, baby poop. And it's really thick and sticky. What do you think happens if baby poop that is thick and sticky gets into your lungs? What happens to gas exchange? It's really challenging, right? So what happens if a baby has, there's different grades of meconium. We'll say light mec if it's like a light green. Sometimes you can barely even see it. And then there's all the way to thick meconium that looks almost like split pea soup. And if you see meconium, especially thick meconium, you are concerned that neonate, that fetus, is in some kind of distress, because babies don't often have bowel movements on the inside unless there's some kind of distress or they're post-dates. So thick meconium, that's going to be really hard for gas exchange. Some healthy babies are still able to do it. And then the NICU just kind of leaves. It's their favorite kind of birth, right? Some babies, even with light mec, they're going to need some help. And what happens is they get intubated and then they get sectioned quick. And if they're able to breathe on their own after that, then they can be extubated. Questions? Yes.
So when babies are prematurely born, they don't have the surfactant in their lungs. Isn't there something that they like spray in the baby's mouth or something to help with the lungs?
They certainly can give them surfactant. I don't know how that process works. I've never seen it happen, and it doesn't happen in the immediate newborn period. I think that that's something that either happens in the NICU once they're stabilized. They also can give them caffeine as well, which is, I think, interesting. Yeah.
With meconium aspiration, are they worried about like bacteria in the lungs too?
What a great question. No. And you guys know why? It's still sterile. Yeah, so it's still sterile at that point, which is pretty cool. Meconium actually it starts as soon as the fetus starts developing. So one of the ways that we will assess for maternal substance use is through meconium, because the meconium will actually contain substance use throughout the entire pregnancy. But it's sterile. So I think that is a great question. Anything else? Drug use and subsequent respiratory depression. So one of my areas of research is in pregnant women that have opioid use disorder and who are incarcerated. And so what do we do for those newborns that come out for women that have used heroin in the past 12 hours? What does heroin do to your body? It essentially depresses your respirations, right? You have a newborn that has those on board, and it might not be able to breathe as well. So we know that there are things that we can do for women who are pregnant and have opioid use disorder, things like methadone, things like buprenorphine, that can help prevent neonatal abstinence syndrome and help prevent the RDS from drug use. We can actually do that, though, for women that don't have a substance use problem. So fentanyl, what is fentanyl? It's an opioid, yeah. Do you get that in labor? Yeah. So opioid you can give it about once every hour. It's most active from the time that you give it, about 5 minutes, until about 45 minutes. So normally we don't want to get fentanyl if we know a woman is going to deliver in the next half an hour. Sometimes you can't tell that. So if you give someone fentanyl and they bomb out a baby, what happens with that baby? It has RDS. So you have to be aware of what you're doing and kind of read that situation, because that's a pretty big mistake and we potentially can't reverse that. So you need to be mindful of the pain medications that you're giving. And then occasionally RDS can be cardiac related. So if an infant has congenital heart malformations, that can lead to respiratory distress. Although, which one do you think is more important? Do you think that it's breathing or the heart that's more important in newborn survival? Yeah, breathing. So actually, newborn's heart rate will come down secondary to respirations. So risk factors for RDS, kind of already talked a little bit about this. Prematurity, substance use, intrauterine growth restriction. Category 3 tracing, which you guys don't need to know the categories, but if you work on a labor and delivery unit, you will. This is an example of a category 3 tracing. Actually, that might be 2. But you can see that doesn't look pretty, right? You wouldn't look at that and be like, oh, it's a happy, healthy baby. You'd look at that and be like, that's kind of concerning. And so a tracing like that should warn you to be prepared that you might have to resuscitate a baby. Structural abnormalities, cesarean birth, and when we talked about the vaginal delivery and that squeezing of that amniotic fluid, what doesn't happen in a cesarean birth? They don't get squeezed. Those babies' lungs are so wet when they come out. If you get the opportunity to listen, if you do a day on labor and delivery and you get to see a vaginal birth and a cesarean birth, take that stethoscope if you can and listen to the lungs, because you will hear a difference. And then a precipitous delivery, so same thing. They didn't get squeezed like they were meant to. Questions about that? So you don't need to know this, but I think people's minds just work in this way, and so I included it. That's kind of how you differentiate between chronic neonatal lung disease and respiratory distress syndrome. And you can kind of see the pathophysiology behind that. This is an example of what you want the normal alveoli to look like versus the collapsed alveoli. What do you think the collapsed alveoli is missing? Yep. And so you can just see how gas exchange would probably be impaired. Signs and symptoms of RDS in newborns. So once again, they're going to be floppy, central cyanosis, meaning their heart or their chest, or their mouth or their chest is blue. What about their hands and their feet? Are you concerned if you walk in a room and a baby has blue feet? No. It's called acrocyanosis, and it's normal for the first 24 hours. Our first-time parent's going to be like, oh my gosh, my baby's hands are blue. Something is very wrong. Yeah, so you have to be able to say, nope, that's totally normal. We're worried about anything that looks blue around the mouth or the chest, okay? Grunting and retractions. So here you can kind of see what it would look like for an infant to have retractions. And it's essentially them trying to use their accessory muscles to sustain their breathing. Grunting, and like they'll sing, they'll make some weird noises. Newborns shouldn't really make a lot of noises when they're breathing. So you'll hear them go, or they'll sing. Okay, so anytime you hear that, it needs to be on your radar that there's something kind of going on. Respiratory rate less than 40 or greater than 60. Sometimes it can translate, if they're screaming, their respiratory rate might be greater than 60. But if they're just laying there and they're chill and it's 60, that's concerning. Heart rate less than 100, that's usually in response to poor breathing. Okay? So these babies, they don't have a lot of reserve. You have to watch them really carefully. Okay? This is just another sign of retractions. That's one of the things you are responsible as a nursing student and a nurse for assessing. We're often the first ones that are going to catch these, okay? When a midwife or a physician delivers a baby, they put it up on the abdomen. It is the nurse's responsibility to assess that baby and kind of communicate with the team what's happening. If you're seeing retractions on a newborn, you are concerned, okay? And you might see it in various different places. Like right here, along the ribs. You'll also see it kind of under here. They're belly breathers, so that one's a little harder. And then there's nostril flaring as well. So nursing interventions. So anytime a baby's born, you're going to take a blanket and you're going to scrub them really hard for 30 seconds, okay? And what you're doing is you're just kind of giving them that jolt that they might need to take their first breath. Okay, you're also going to kind of help keep them dry because, as you learned, it's really important that they don't stay wet and then they're going to lose that heat. Within the 1 minute and 5 minute, you're assigning the Apgar scores. If a baby is not breathing by 30 seconds, you are bringing that infant to the warmer, okay? You are going to initiate resuscitation depending on your facility. If you have a NICU button, you go ahead and hit that. If you are alone, you go ahead and you start. Draw cord gases if needed. Does anyone know what cord gases are? So cord gases is a way of looking at the acid-base balance in the fetal blood to assess for signs of brain damage. So potentially if you have a baby whose cord blood is very acidic, they might need to start cooling. So they would be, once they're stabilized, they'd be put on a cooling blanket and their body temperature would be brought down to prevent any type of brain swelling. And then outside of delivery, that newborn's always on your radar. Most of the time, after the first 2 hours, they're pretty stable. But if there's ever any concern, you guys are going to be spending a lot of time with these patients. So the nurse and your clinical instructor, they might not always be in the room with you. So you guys keep an eye on this. And that's why one of the reasons why this is so important. So this is what a resuscitation might look like. Usually you have a provider, so most hospitals will have a neonatal nurse practitioner, and they're at the front of the baby house, what is this called? The warmer. And you can see this woman or this person is using an oxygen mask, and they might be using PPV, which looks a little bit like CPAP. It's positive pressure ventilation. It's just kind of keeping those lungs inflated or inflating them for the first time. And then if needed, if that's not enough, then you'll initiate breathing for that baby. This is usually run by an NNP, a nurse, and then respiratory therapy. So you'll probably hear me say this 20,000 times. I love labor and delivery because it's every specialty. right? You're triaging like the ED, you have critical care like an ICU, and then your peds because you have newborns. And then you also have happy, healthy babies. You've probably seen this. I'm going to show it to you anyways. And I think this really highlights the role of nursing, and I'm already going to cry. So if I'm crying in the corner, it's not me saying, it's me saying.
I have a story to tell about something that happened to our family last week. I'm sorry. I try not to get emotional, but it was a scary story. And before I go into it, I want you to know it has a happy ending, okay? So when I'm telling this, don't get too upset. Leave that to me. But a little over a week ago on Friday, April 21st, my wife, Molly, gave birth to a boy, a baby boy. His name is William Johnson. We call him Billy. It was an easy delivery, 6 pushes, he was out. And he appeared to be a normal, healthy baby until about 3 hours after he was born. We were out of the delivery room. We moved to the recovery room. Our whole family was there. And we introduced him to his 2.5-year-old sister. She was cute with him. We were happy. Everything was good. My wife was in bed relaxing. And when a very attentive nurse at Cedars-Sinai Hospital, her name is Nunush, was checking him out and heard a murmur in his heart, which is common with newborn babies, but she also noticed he was a bit purple, which is not common. So she asked me to come with her, and my wife and I assumed it would be nothing. Our daughter had a heart murmur too, and we didn't notice that he wasn't the color he was supposed to be. So I accompanied Billy and the nurse, went down the hall to another part of the hospital, the neonatal ICU, where another excellent nurse named Ann checked him out and called the doctor in. And now all of a sudden it felt serious. And the room started to fill up, more doctors and nurses and equipment started coming in. And they determined he wasn't getting enough oxygen into his blood, which, as far as I understand, or understood at the time, was most likely one of two things, either his heart or his lungs. And you hope it's the lungs because sometimes they have fluid in them after delivery, and it's potentially a minor thing. But they did an x-ray, and his lungs were fine, which meant his heart wasn't. So now more doctors and nurses and equipment come in, and it's a terrifying thing. My wife is back in the recovery room. She has no idea what's going on. And I'm standing in the middle of a lot of very worried-looking people, kind of like right now, who were trying to figure out what the problem is. And it's Friday night, and so they call a pediatric cardiologist, Dr. Eben Zahn, who, when they called him, was picking his mother up from the airport. Luckily, her plane was not delayed because he got to the hospital very quickly. They did an echocardiogram, which is a sonogram of the heart, and found that Billy was born with a heart disease, something called tetralogy of Fallot with pulmonary atresia. It's hard to explain. Basically, the pulmonary valve was completely blocked, and he has a hole in the wall between the left and right sides of his heart. And then they brought my wife in, and they wheeled her in, and Dr. Zahn told her what was going on, what our options were. We decided to take him to Children's Hospital, where there's a world-renowned cardiac surgeon who is, by all accounts, a genius. His name is Dr. Von Starnes. So we put the baby in an ambulance to Children's Hospital, Los Angeles, and on Monday morning, Dr. Starnes opened his chest and fixed one of the 2 defects of his heart. He went in there with a scalpel and did some kind of magic that I couldn't even begin to explain. He opened the valve, and the operation was a success. It was the longest 3 hours of my life. Another open heart surgery in 3 to 6 months to close those holes.
And you guys will get to learn more about tetralogy, and you might even see this clip again with a different guest speaker. So I'm not going to continue to watch it, but I think that, did you guys almost tear up? I did. I think this just highlights the important role that nurses play, and you should be very proud of the profession that you're going into when you watch clips like this, because we are the eyes and the ears for our patients, and we're advocates, right? Like can you imagine being that nurse? But when you are in an emergency, which you always will be, I also want to encourage you guys to think about the family that's in there. Obviously, there's certain things that come first, like patient safety. But if you're another set of hands, someone gravitate towards the person that's watching that and explain what's happening, okay? Because poor Jimmy Kimmel didn't know what tetralogy of Fallot was before this. And so making sure that you're kind of aware of the situation as well, I think is important. And that happens a lot in labor and delivery, where people will forget about the partner. And so as a student, that can be a nice role for you if you kind of understand what's happening, or even if you don't, you just go over there and you kind of pat him on the shoulder. Okay? It'd be really scary to watch a newborn that you're pretty invested in, right, and your partner potentially have any serious complications. Questions about that? That kind of highlight and make this real about why we do the work we do?
Yeah. And you know what's so cool is nurses with every single newborn on the postpartum unit, they will do a measurement of the blood pressure, of the oxygen saturation. And what happens is if there's a discrepancy of 3% or more, okay, then they go and get an echocardiogram. And it's just to tell us a little bit about some of the defects that we know on heart disease, that the babies that we just can't pick up because not everybody gets a level 2 ultrasound. And if we need to know more about that, I can share that with you. But it's just a screening, and it's very, very accurate, very accurate. And so some of these babies would have gone home and started to turn blue, maybe day 3 or 4, or maybe even right before that, and we catch it. And it's one mom's plight. Her baby had this, not exactly what Jimmy Kimmel had. It was CHG, right? CCHD. And so anyway, I can send you a link on that. It's really kind of a neat way that nurses then just screen and then the babies as they need to.
Mm-hmm. Ah, what a cool profession, you guys. Mm-hmm. Terrifying, but really cool. All right, speaking of terrifying, we're going to move into neonatal sepsis. This is something that will give most L&D postpartum nurses, this will give you nightmares. So it starts off pretty subtle, and if you miss those things, it can progress into ultimate death of a newborn very quickly. So this is something that's really serious. So we'll define it, we'll identify causes, help you understand risk factors, describe signs and symptoms, and then determine nursing interventions. The definition is it's an infectious organism in your blood. So early onset, it's acquired from mother, and onset is within 72 hours. Late onset, it's not always acquired from birth, and the onset is after 4 days. So this is something with the baby that you're worried about that you might start seeing, 4 hours. You might start seeing things right away, especially with certain conditions, which we'll talk about. So similar to an adult, it's just the bacteria that's in the blood that your body's not able to fight off. Common causes of early onset neonatal sepsis. So GBS, this is one of the reasons that we kind of hound you guys about this. We want you to know your patient's GBS status. We want you to know if they were adequately treated or not. What does it mean if a woman is GBS positive and that she is adequately treated? Anybody know? Okay, well you should know this before you go into clinical next week. Adequately treated GBS means that you got 2 doses of ampicillin at least 4 hours apart. If a woman has an ampicillin allergy, they're going to use a different drug, but they need 2 doses of every drug. Some of those drugs take 12 hours in between the first administration and the second administration. Okay? The key thing here is not that there's actual 2 administrations, it's that you have that 4 hours, because what do you guys know about antibiotics? Usually right at the time that you're going to give that next dose, okay? So that ampicillin has reached its peak at 4 hours, and you're just going to sustain that peak with the next dose. All right? E. coli, Staphylococcus, Haemophilus, Listeria. Okay? So what happens is that it's an ascending infection that reaches the uterus, and usually it comes from the vagina. Okay? So we have normal, healthy, happy flora in our vaginas. GBS happens to be one of the normal flora for some women, about 10% of women. And I know it's kind of weird to talk about, but a lot of times the bacteria that's in our gut and can come, we share bacteria between our vagina and our rectum happens. Okay, it's actually pretty cool because the uterus and the vagina are normally really good at regulating that and keeping everything clean. In pregnancy, and in birth in particular, when you are ruptured, So prolonged rupture is definitely a consideration for neonatal sepsis. That bag of water, which acts as a protection from the normal, healthy, happy bacteria that lives in your vagina, it's broken. And the amniotic fluid has a lot of nutrients in it. So what does bacteria want to do? Wants to get in the uterus. Okay, so that bacteria can actually cultivate and live in that amniotic fluid. Sometimes the amniotic fluid, it actually feels like a biofilm, and you'll feel that biofilm even on the placenta. And then an infection happens. And the infection for mom is usually resolved with delivery. We're going to give them antibiotics, and that's fine. For neonates, it's a lot more serious. Okay, so for every woman that has GBS, we want them to get 2 doses. That means that they're adequately treated. The likelihood that their infant is going to become septic, pretty small. If a woman has GBS and she's not treated, or she only receives 1 dose, we're concerned. Oftentimes, those babies will stay longer in the hospital because we want to watch them closely. And then GBS is the leading cause of neonatal sepsis, but the other ones are definitely a part of it, okay? Questions about that? Yeah.
When do they give the group B drug? When do they give that? Like
The
during
test.
labor?
Yeah, so the question was, when do women receive the GBS swab? And the GBS is collected at about 36 weeks. So what happens is GBS is kind of a transient bacteria. So you, like, if you theoretically were to swab a woman at her first OB appointment and then again at her 30th OB appointment, she might have it once and then she might not have it again. But we know that it lasts about 5 weeks. So we really want to make sure that if a woman doesn't have a swab by 36 weeks, that she might not be covered for when she's theoretically going to deliver. So a swab that's older than 5 weeks is no good, and you'd have to redo it. If a woman is delivering before she's had a GBS, we'll do a rapid, which is not as accurate, or we'll just treat prophylactically. Most hospitals will do that. Every hospital is a little different, but most hospitals will just give it with the assumption that she might have GBS. Okay? So risk factors, choreo, GBS. You can have choreo without being group beta strep positive, and that's usually those other bacteria that's normal that just ascends. Signs and symptoms: temperature instability, respiratory distress, pathological jaundice, poor feeding, lethargy, bradycardia, seizures, and diarrhea. I bolded the ones that you're going to see most commonly. Temperature stability, that's a really hard one because neonates are not able to regulate their own temperature. We know that low blood sugar can cause low temperature, but another thing that you're thinking about in an infant or a neonate that has consistently low temperature is you want to make sure that they're not septic. Okay? Poor feeding, kind of same thing. These are all really vague symptoms. And if you're a first-time parent and you have a newborn that you don't know, are you going to know that they're lethargic? No. So these are things that nursing is most often the ones that are going to catch. So nursing interventions, you're going to adequately treat. You're going to know signs and symptoms of choreo in women. So what kind of things do you think might be signs and symptoms of choreo, or now what we're calling triple I, intra-amniotic, intrauterine infection? What are common infection signs and symptoms? A fever. Yep. So if you have a pregnant lady that has a fever of 100.4 or greater, you're going to retake that temperature in a half an hour. If it's still 100.4 or greater, you're going to call a provider. But we already know that sometimes the medications that we give, including an epidural and then also Cytotec, can cause those low-grade fevers. So usually they need other qualifiers as well. So besides the fever, what else?
Fungal odor?
Oh yeah, definitely. If you get a funky odor,
never forget.
Yep, you know. I recently had one. Everything I had to not throw up. What else? What happens to the white blood cells? Decrease? Increase? Decrease. Yep. So you'll see white blood cells that go above 15. And pregnancy is kind of already, you're more likely to have higher white blood cells. But anything above 15 should be concerning for an acute infection. And then what do you think about our uterus? Is it going to feel great? it's gonna feel painful to have your uterus touched. Okay, so you also want to make sure that you're going to identify neonates that have risk factors, and then you're going to administer neonatal antibiotics. So infants that need antibiotics, we're actually moving towards keeping them with their parents. So pediatric nurse or NICU nurse or a specially trained postpartum nurse will administer the IV antibiotics to the infant while they're rooming in together, which I think is really cool. So look for more of that in your sites. If they don't do it yet, it's probably coming. Questions about sepsis? Babies that die in the Twin Cities that don't have congenital abnormalities, a lot of it is either birth trauma or sepsis. Okay, so it's something really important to think about and to always keep on your radar. This is why newborns are hard, right? They can't tell you what's happening. Same with peds. You just kind of got to watch them and be like, this doesn't feel normal to me, or this doesn't feel right, and then ask your friends that have a lot of experience. Sometimes they'll be like, it's fine. Sometimes they'll be like, no, you're right. Right on. Okay. Preterm birth. What time is this class done? Noon?
At noon.
Okay.
Yes. They are about an hour and 15 in, so they might see about a break or how everybody's doing.
Do you guys want to take a break before we finish this and
Yeah. Let's do a break again.
I know, sorry, we're like ending, like I know we're so close, but just take it while I can get it, right?
Yeah,
if I forget and you don't even get one.
Let's take 10 minutes and be back, a little over 10 minutes, and be back at 11:15.
They want a coffee?
Georgia.
You're going to hang out with me.
I could ask you. Did it work?
It did work. What? Did it work?
Probably.
I did know that because they were like,
yeah, they did. Sometimes it happens low, but yeah.
Where are you going?
Well, it's been closed for the whole year because of that.
Oh, it's probably what you're gonna see for bleeding.
Do they have to rebuild?
I'm going for my photos.
Yes, let me know. Here's some problems. As soon as you have height, it just gives you both ranges on both of them. Okay, yeah.
It needs to be pretty.
Thank you.
I'm so mad.
Why?
Throwbacks.
You need to say it louder.
Professor Jimenez, I just have a question. So for the alternative for this ATI exam, I was gonna sign up for it, but it's on view only. Like there's no editing access. So I was wondering if.
Dr. Durst. That's
Okay.
okay. I'll let him know. Thank you. I'll write it right now so I don't forget.
Practice this with our
The practice. There's one.
Are you going to the gym after this again? I am. Are you?
Versus.
Sounds good. I ever go to the gym? Your boss just always said bananas.
Well, I have to eat them when we go back.
Like I have 2 a day.
I know.
Like you get like 7 or 6 or whatever.
I even buy them when they're like,
I buy one so green.
I know.
But then I don't like it. I like a certain product.
Alright.
It's really
What's up? Are you done?
That's what she said. It's a nice drawing.
Thanks.
Hurt down here after talking about
Hey.
this. How brave is this? I want this to know that you never have to do any of it.
What up, Mike?
You're not going to feel the pain.
I can have empathy.
I didn't say it was empathy. I think yeah. You're You don't have to do it. That sounds horrible.
That's why women are stronger.
Oh, so I have. Very much so cool.
Yeah.
Where floats your boat?
I literally ran to my I was like, I was like determined to go. I know. Like 25 is the thing. That's it. Bro, there's something I would. Oh, you guys got it. Right. Finished. I was like, I should.
Probably.
It doesn't work. I was gonna ask you. I wouldn't be surprised. I'm gonna have to say your answer what it means.
Probably not, because we have an assignment due like next week.
No, it's reverse. Honestly, I understand more inside out travel letter. So as it looks inside out.
It's probably because we hyper-focus on stuff. And I just
I need to watch.
I had to switch it up. I know. I knew you were wearing it today, so.
I think if I looked at it right, that sounds right. And then maybe you should talk to this at 17.
No, ADHD is
the water.
Isolated.
But that's if you can focus, like if you're stimulated and then your focus needs. Right, so then you're gonna stimulate that, like inattention.
That's
what happens.
Have you ever heard people take Adderall and not being that's because they are otherwise it just doesn't work.
Automatic.
Well, I don't know where they are.
That's why like some people like too much Adderall, they just stay up and be
exactly what I want to do.
Only if you don't have it.
Right, then it would happen.
It's opposite.
Yeah.
So like, it's all at one girl, like I calm down and focus. But like somebody who doesn't have it, they'll take it and they're like, can't do one task at a time because they're like, do this, step in that, start this.
Right, so that's why like some people who don't have it, they take it during finals. But I feel like you shouldn't do it like
And I thought I did really well. I just don't like when you say I was like, that's not how you feel about, and then at the end I was like,
That's okay. Send me an example sounds.
Doing some eye care.
there was meant to be a little thing, so.
You know.
You did?
Bounce, you just.
You
Somewhere else. You just don't.
No.
I do all my lunch.
No, I don't.
I do.
No, when in that way, I can't do
I'm not telling you where.
Maybe like a year ago. Like now,
I read all good luck. I just applied to
What?
No, don't do that.
I did, yeah.
I wish I that day there was something I just like betting. Or you know they used to
Like way back.
fine.
You're the one
One year like
I know. Here.
and then after we're all done. Like complexity. You drafted.
Like get off.
One of my friends that were using but yeah.
Oh my god. We only have very rude.
Yeah.
anyways.
I understand that.
I can. So it might be worth it.
This, $100. Yeah.
I just want some margarita and.
So I don't know. Like when it gets cold, our house cannot get like a plastic.
I died.
Wake up, you put on like which is fine, like I get it. Sometimes I wake up like
Really? Mine's actually. I think that's why I just don't want to be. I cannot do it. Terrible year. Have you ever read that matters? I don't. Okay, well, basically, that's all. This is my saving grace.
I just can't wait.
Eight also. Right, like I just like, you never know.
It doesn't really matter.
Okay. Never know. I know.
Which
Dinner. Man,
over
look at that.
like
It's cookie in your pocket.
like that they work that well.
No, you'll be fine.
I promise. We're going to Union Hospital. You guys are so much better off ordering that.
This past week.
I mean, there's sexual assault.
It was past week.
You were in psych.
Anything I
$30 an hour.
Yeah,
$45. First floor. Because I was like screaming the 5 around.
but the sidewalks were maybe. When I'm at home.
Yeah.
And I don't think like it's
Have you like gotten a
Well, I'm not like,
never
it's okay.
Yeah. It's like
My going to the show. I haven't been to the gym in 2 weeks, and that's why it's
join the sport.
I just like
What sport would accept you?
where I would.
Non-sport.
Friday, May 10th from. Yeah.
You get a huge difference.
Just 10:30 to 12. Why is that? And you know what? Only given out.
It also like costs me. But you're my brother.
Get it out.
Yeah.
Okay, I have to get my apartment. I'll just yeah, I know. So I've got 4 classes.
Like, I know it's overwhelming. And I was like, I do making money.
He's like, I think that's something for me personally.
Waiting to see that was good.
We're gonna do it again.
Like you're not.
I am we're just talking about how I always take 30. I'm glad I forgot. Always. Years. But I'm not. So the first time, that's why he's used it. He's 38. Yeah. So constantly when I come in, I'm like, oh, you're right. You're morning time.
I was really, when you're like, oh, this is probably one gap. Or just like, what? And I was like, I would put that in my calendar.
I'm sorry for that.
No, it's okay.
And here's the morning time. Downtown.
This one was 7:40. This one lit up and she'll come in. You're the same. Oh, now you. This one.
Now you're gonna go.
All right, let's go ahead and get started again. We just have a couple things to wrap up quickly, and then we'll do a food. So preterm birth, we're going to define it, identify causes, understand morbidity and mortality, and then describe some nursing interventions. Look at this little cutie. So preterm birth is birth of a living fetus from weeks 23.0 to 36.6. And the reason that we start at 23 weeks is that's the age of viability. So and it's actually starting to decrease at certain hospitals. They'll take infants 22 weeks and above. But in the Twin Cities, hospitals will not likely resuscitate an infant that is younger than 23 weeks gestational age. And there's some things that go along with that, including ethics consults. And by and large, when the age of viability is a very huge, as you can imagine, ethical concern. So when you consider resuscitating a newborn, you're thinking about long-term morbidity and mortality rates. Okay, but look at this little guy. So we know that babies develop best on the inside. Okay, sometimes they develop better on the outside. So certain conditions like IUGR or conditions like cholestasis, where your body actually is not providing them a safe spot, like safe space to grow anymore. They might grow better on the outside, and we'll take them. Twins are often preterm birth, and that's because there's just not always room. Upper order multiples, there's definitely not enough room. And so preterm birth is becoming more talked about because we can help these babies live. And sometimes we can help them live the quality of life that a term baby would have. So really most people, like where I worked, we took 23 weeks and above. You have to have a level 4 NICU to be able to do that, so we were attached to Children's. At 30 plus weeks, we weren't as concerned as a woman that was in preterm labor or had PPROM below 30 weeks. And that's just because newborns have better outcomes at 30 weeks. That being said, you could have a 23-weeker and they're totally fine 10 years down the road. You could have a 36-weeker and they might not survive. So it's so situational, so environmental, some of it's genetics, and it's really interesting and really challenging to be a parent of a preterm infant. But you can see a lot of things that these little dudes have to kind of deal with, right? They've got these huge oxygen tubes, they've got umbilical lines, they've got pulse oxes, and they're in these little incubators. And I know that this discussion can be kind of triggering for people, and if you just need to leave, that's okay. A lot of you have probably been impacted by preterm birth in one way or another. Sometimes there's even people that were preemies themselves. Oftentimes if you're multiple, you were a preemie. So causes of preterm birth, PPROM, and what does that stand for? And you're just like a hoot on this. Well, that was prom, I guess. So pre-prom is premature, but we're actually transitioning to pre-labor, premature pre-labor rupture of membranes. Okay, so sometimes where I was working, we'd get women at 23 weeks, their water spontaneously breaks, they come in, and then they're stuck with us until we deliver them at 36 weeks. So PPROM can be a really big thing. Infections, so sometimes women that have normal vaginal infections like a yeast infection or BV, that can cause irritation and can cause preterm birth. There's this term called incompetent cervix, which I don't love because nothing about your body is incompetent. But that means that your cervix is not able to maintain its structure throughout the course of the pregnancy, and as the fetus and the amniotic sac gets heavier, it starts to efface. Uterine structural abnormalities. Some people have 2 uteruses. There's not enough space in their abdomen to hold 2 uteruses, one that's gravid. High-risk pregnancy. So women with diabetes, preeclampsia, or hypertension, those are often that category where we would take the baby earlier than term for the baby's sake. And then sometimes for mom. These can be, women with preeclampsia can get incredibly sick, incredibly fast, and being on magnesium is awful, and sometimes being on magnesium is not enough. And if you start to have kidney failure, we will prioritize maternal health over fetal health in some of those cases. An abruption. So who can tell me what an abruption is? What does it sound like? An abruption is the separation of the placenta from the uterine wall prior to delivery. So what is happening in that situation? Is the fetus getting blood circulation? And there's different levels of an abruption. You can have a small chronic abruption, but when we talk about abruption like this, what we're talking about is half the placenta is now separated and the woman is bleeding and that fetus is getting half the amount of circulation that it had before. In a uterine growth restriction, that kind of goes along with the high-risk pregnancy. It's pathologic, right? That infant's probably going to grow better on the outside than on the inside. And then fetal indications. So certain abnormalities, sometimes babies will tell us that they're ready to come out. You put them on the monitor and you're like, it's time. And that's regardless of gestational age. Questions about that? Okay. So morbidity and mortality associated with preterm birth. Once again, this is a huge spectrum. Some babies can make it out of this and be totally okay. Some babies are going to have some significant lifelong things that are happening with them. So the most common thing that we think about is intraventricular hemorrhage. I talked a little bit about cooling blankets before, and what that cooling blanket is designed to do is to take that baby's temperature down to the point where the brain swelling isn't happening as badly as it would have at room temperature, and hopefully it's preventing that bleed. It's kind of like a hemorrhagic stroke in an adult, okay? Respiratory distress syndrome and pulmonary hypertension. I'm not a pulmonary hypertension expert, but I can tell you that it often restricts their ability to breathe and restricts gas exchange. And then necrotizing enterocolitis, once again, not my specialty, but my basic understanding is that their GI tract is kind of decimated. So nursing interventions. You are going to use medical interventions to prevent delivery. So what things do we have in our toolbox that we've already talked about that might help prevent delivery? Terbutaline. Yep. What else? Dr. Summers touched on it a little bit in the Kahoot. Magnesium. Yep. And once again, it's a smooth muscle relaxant. So we might use that to prevent preterm. It's also really good for neurodevelopment of preterm infants. So it kind of serves a double function, and actually we've really transitioned away from using that for preterm labor and towards neurodevelopment. Okay? Anything else? Fluids. Your uterus is a huge muscle. If it's dehydrated, it's going to be irritable. You're more likely to kind of contract. Okay? You're going to assess for vaginal infections, making sure that they don't have BV or yeast, which could be triggering this. You're going to address fear and anxiety in parents. I'd like you guys to put yourself in that situation if you're able to, and imagine that you are 26 weeks pregnant and you know that it is not time, that you are contracting. Okay? How scared are you? Okay? You're watching your newborn in the NICU. How scared are you? Supportive care for grief. Sometimes these parents are making really challenging, hard decisions. And then you're going to promote breastfeeding. Regardless of gestational age, your breasts will have colostrum in them, and you want to help women start to hand express or use a pump. Okay? Breastfeeding, the more we know about skin to skin, even in a newborn, as soon as their skin can tolerate skin to skin, because their skin can be pretty fragile, you want to be doing as much skin to skin as you possibly can. Okay? Breastfeeding goes right along with that. We know that donor breast milk is a close second, but it doesn't compare to breast milk, and especially breast milk from mom, because we give good bacteria to those babies. We know so much more about bacteria now in our GI. We also make antibodies. So if your partner's sick, your body's already ramping up those antibodies to that illness, Then you're going to give them to baby. Okay? So cool. All right. Questions about that? This is we just covered so much and not a lot of time. Okay. So we're going to do a Kahoot. Because I really enjoy them. Although you guys weren't as into them as I would have liked to see this morning. So again,
we're trying to wake you up by them.
So what I really like
Kahoot in the morning.
I want some creative usernames here, people. They're still respectful, but creative. Okay? Respectful, creative.
Like
Alrighty.
I made this on the phone, but it isn't.
Floppy baby. Let's get some. I want to hear some creative ones.
This just makes my heart happy. Ah!
Living fetus like those.
I saw the boggy fundus earlier. That's a good one. IGA.
I was like, ooh.
Becca, we're creative there. Okay, not for me. You know what? You never know until you're there, my friend.
It might be a Manchester.
Who's the OB not for me, if you're willing to say?
I don't know, I will. Is that Corey?
Okay. One of my best friends she is a woman, or she's going into mental health nurse practitioning, and OB is not for her. Once she was like, Megan, there is pubic hair.
Oh, somebody's me on there. Who's me? Who's claiming me?
I think you got two.
Why?
Diesel Weasel. That doesn't feel very OP related, but bicornate uterus, I appreciate. What are you at risk for with a bicornate uterus?
Never having a baby. Yeah.
Rogam the boat. Uterus. Walk it off. Percreta. You guys, look at you. You know what a percreta is.
Looking for more. We need more.
How many do we have total?
I know.
We just had a patient that had a 4th degree.
Yucky. Where's hematoma? Hematoma. I saw your look on your face.
We're having babies. Anyone else?
I'll join right when they start.
Sophie.
Don't say no yet.
All right. Okay. Anybody still working on that?
There we go.
I respect that you hate it. It can be anxiety producing. Sick though. All right. Are you ready with the Goldie Gopher that's cut off? All right. So a lot of these come from hopefully the things that you watched. How many umbilical veins are present in normal fetal circulation? Where is the music here?
It's okay. It's okay.
It is not okay. That is the best part. It's seasonal themes often. Are you Googling it right now? Alright. How many umbilical veins are present in normal fetal circulation? Alright, is this intuitive to you? Yes. This is intuitive to you? 1 vein and 2 arteries? Okay.
Let's make sure. We got half the class that said it wasn't.
Okay, so this is not intuitive to me, right? And when you look at the smiley face, that is the umbilical cord. There is 1 big mouth and 2 little eyes. Which one is the big one? The vein. And then 2 arteries. Which way does the blood flow?
Vein has oxygenated blood.
Yep, so the vein has oxygenated blood. The arteries carry deoxygenated blood. Okay? So that is the exact opposite of adult circulation, and it changes the second that umbilical cord is clamped. Okay? Any questions, comments, or concerns about this? Concerns? Okay. Will these kinds of things pop up on the NCLEX? Yes. UTI, you're doing good. Doing good. UTI, is your name also Morgan? Because we're gonna knock this down this time. Alright, which is not a function of the placenta.
Poor Morgan.
Yes. Maintains the pregnancy through hormone secretion, facilitates oxygen transfer, provides a selective physical barrier, and creates unique nutrients for the fetus. I don't know who Morgan is, I'm sorry.
It's me.
Okay. You're doing really good. We're proud of you.
We don't want to single you.
I know.
We have fun. Just keep it
There's
away.
nothing wrong with the cheating.
She read.
Yeah.
Good, yeah. So that's
All right. So which is not a function of the placenta? It doesn't create any nutrients for the fetus. This is kind of a challenging question, so if you don't get it right, that's okay. I can feel that I'm like losing you guys. Just like half an hour. So it does certainly maintain the pregnancy through hormone secretion. We talked a little bit about which hormones it secretes. Provides a selective physical barrier. What kind of things can get through the placenta?
alcohol. Blood sugar.
Alcohol. Blood sugar. What else? HIV? No. Nope. So that's why a woman can be pregnant and have HIV, and the fetus doesn't necessarily have it. If she's newly infected with HIV, it's a different story, but most women, it's like a 2% vertical transmission rate in Minnesota. So some things, that's why it's selective. And then it doesn't, this doesn't create any nutrients for the fetus. Once again, if you were taking this as an NCLEX, you would just kind of have to think through these things, right?
In terms of those types of questions where there is it kind of trumps you up and it says not, so some things are true and some are not, you're not going to see a ton of those, and I only have a few of them, so I'm going to be honest with you, I do have questions like this. And so you're going to see a different type of question that's going to show up, but not a ton of them, because we know that in the NCLEX we don't have a ton of them, but you need to know how to do that and how to change your brain from looking for the one that's not right for the one, right, that is right. Okay, so just slowing it down and reading the question correctly.
Firm uterus. Hey, we're mixing it up. All right, which is not linked to a neonate's first breath? Temperature change, clamping of the cord, maternal voice. I gave you guys way too long for this one, sorry.
Okay, when you don't have the music.
I know, it sounds fun. Okay, so temperature change and clamping of the cord are certainly related to neonate's first breath. And why might that be?
Get somebody in Rochester.
Whose OB is not for me?
Corey.
I'm just going to keep asking. Still happen.
Wait, what happened? What was the question?
Corey, I feel like you might not be paying attention to me, which is fine. I guess I'll accept it. But why do you think that the temperature change and clamping of the cord has to do with the neonate's first breath?
Well, as far as what I remember being in the when they're born, the temperature is one of the main things they check in the Apgar. And the clamping of the cord, it has to do with so much time between delivery and birth, the cord has to be clamped.
Yeah. So I can see why that would be confusing and why you guys might have chosen that. So clamping of the cord is just one mechanism. We don't fully understand what actually tells a newborn to take their first breath. When you clamp the cord, you're changing their circulation. So potentially that could be a component of the neonate's first breath. Certainly temperature change, right? You're probably really nice and warm, floating around in that amniotic fluid, and you come out and it's 20 degrees colder, right? And then maternal voice. Can fetuses hear the maternal voice in utero? Yes. Yeah, absolutely. I think that they just might be a little bit too confused to really process what's happening when they come out. Now, I haven't personally been able to speak to a neonate about that, but that would just be my question. So there's a lot of things that go into this that we don't fully understand what prompts them to take their first breath or what prompts them not to, right? But those two things are things that we usually think about.
I have a question just based on the cord clamping.
Yeah.
This is Barbara. So is there a risk for delayed cord clamping then based on, I mean, is the assessment done with the infant's first breath and delayed cord clamping?
What a great question. So, I mean, no, there's not a risk. But also, when a baby's not breathing, one of the first things that we'll do is clamp the cord, right? You have 30 seconds. And so if you're a provider and you see that the baby is near 30 seconds, so hopefully your nursing staff is being like, we're at 30 seconds, and you know you're going to start clamping. So there's really not a lot that we're going to do. And actually some midwives, if a baby needs to be resuscitated, have started resuscitating on the abdomen to keep that blood flow, because the placenta can potentially be perfusing that fetus for an additional 10 minutes, 20 minutes, 30 minutes. So some midwives, especially in birth centers, will actually keep the umbilical cord still connected to perfuse while they're doing resuscitation measures. In a hospital, you'll never see that. They go to the warmer instantly. But once again, another area for research, potentially.
Other countries resuscitate their babies attached to the cord. There's lots of research about that. They actually have like a cart that wheels over. The baby sits on there, but it's still attached. They feel like that's part of the resuscitation. Is the cord being, still being attached? And I would say the number one thing that causes a baby to take its first breath is going to be when the baby hits the head comes out. You're at risk. You only have about 1 to 2 minutes before secondary apnea sets in. You have primary and secondary. Primary is totally fine. That's just where they're stunned. They're not going to have, but they will want to take their very first breath as soon as that head hits that air. That's their number one thing. In water births, we have that same thing. If they come up out of the water, they can't go back down because already they're going to be starting to breathe and have transition. So that if you don't have a breath right away, you're going to try other measures, right? Before clamping the cord. You're going to rub their backs. You're going to dry them off. You're going to do this all on mom's tummy. We used to just take them away, but more and more we're doing a little bit more effort just to keep them there and get them to start to breathe. It's normal for them to be a little stunned. They might look actually arched back, look up at you like, what just happened to me, still blue, and then all of a sudden they'll get that first cry and you'll start to see them pink up. And so all of you will be able to see that. And we have a lot of tolerance for that. Mm-hmm. It's normal.
Most babies don't come out screaming. You're like, yeah, great job. Mm-hmm. Most of them take a couple seconds, 30 seconds to warm up, decide they're ready. All right, speaking of water birth, all babies born in water drown. True or false? All right. So water birth is something that most of you probably won't see in your clinicals. They don't happen super frequently. It's really only midwives and family practice docs that are doing them in the Twin Cities. But we know that when it's really the temperature change that kind of stimulates babies, among other things, potentially. But the water in the water birth it's monitored to make sure that it is nearly the same as the temperature on the inside. Okay, so the baby can theoretically come out. It doesn't get that signal to breathe. And so some countries, like here, you have 30 seconds to get them out of the water. Scandinavia, they let them hang out, right? They kind of swim around. Because babies have these remnants of these reflexes to swim, to walk. And they'll lose them the first 30 days, whatever, but it's pretty cool. So they don't drown unless you pick them up, give them stimulation to breathe, they inhale, and then you were to drop them, or you were to realize that they weren't above. So water birth is pretty cool. Yeah.
So in theory, if the baby were born in cold water, that would be not.
Wouldn't be good. Yeah. I don't know what would happen, but
yeah, they don't like
that.
That
Would be bad. This might not be the greatest time to ask, but who in here, if you chose to have children or adopt, I guess, would think about a water birth? Yeah. I'd be knocked up. I would. Yeah. And there's lots of benefits to having a water birth, and one of them is the kind of the easier transition for the newborn. Okay, so babies that are born in water, when they come up, they actually usually don't cry right away, but their heart rate and their respirations are fine. So they kind of have an easier transition. They have a little bit more time to like figure out that they're on the outside, and they don't scream, and they're not as cold right away. As a nurse, that can be really terrifying to watch. You're like, why isn't this baby crying? And you're listening, and you're like, well, I guess it's fine. But I think it can be a really great way to manage pain, and then to kind of like have an empowering birth, which we don't talk a lot about. All right, doing good. Rueda, taking butt, taking names. All right, which form of heat loss is common immediately after delivery? I'm giving you guys way too much time here. Are you answering quickly because you know it, or because you don't? This is, I have to like look this up every time. All right, evaporation. So, why? And what is the amniotic fluid? Is it the same temperature, colder, or warmer? And so what happens? The cold air around will suck it up, right? Okay, just like if you guys get out of a shower. One of the reasons why we stimulate babies for the first 30 seconds is to make sure that we're getting that fluid off of them and to also stimulate them to breathe. Like, hey, heads up, you're out. To do something. Okay. What is the primary route for taking a newborn's temperature? Oral, axillary, or rectal? Okay, axillary, yes. So we really don't take too many rectal temperatures anymore. That's only if there have been like a succession of cold temperatures and you want to actually assess what the core temperature is. Rectal temperatures are more likely to cause a perforation of the bowel. Oral temperatures are not. You can't get a good one in an infant. Axillary can be really challenging. So when you guys are in clinical, this is an important thing. They have vernix on them. What is vernix? The cheesy, waxy substance that they use to protect their skin against the amniotic fluid when they're in utero. It's still there, and it's especially there in the creases. Okay? What part of your body has a lot of creases? Your armpit. So if you keep on getting like really cold temperatures, lift up their armpit and see if there's vernix in there and wipe that off. Check the other armpit, wipe it off, and then do it in the other armpit. Okay? Because if their core is cold, one armpit will not be warmer than the other. But you want to make sure that you're not getting like the vernix, and that's what's making it cold. Okay? All right. Who's going to throw them for a loop? What is not a cause for neonatal temperature instability? Hypoglycemia, hyperglycemia, low body fat, or inability to shiver. So what is not a cause? All right. So hyperglycemia is not a cause of neonatal temperature instability. Hypoglycemia certainly is. Low body fat, definitely. So those fat babies have a lot more reserve, and they're also able to keep themselves warm. And then remember, babies can't shiver, right? So they cannot shiver. If you see a baby shaking, it's called jitteriness, and it's not their body, like their body is not able to regulate its own temperature. Okay? Ovaries over brovaries. Good job. I guess greater than. Which method of warming a neonate prevents convection heat loss? Convection. Okay, so this one is going to trip you up, right? These Like the mechanisms of heat loss is a really tough one. That's one of the nice things about having access to the voice threads, and I'll post what I can find of the PowerPoints up for you guys later. But placing infant skin to skin is convecting heat warmth, right? So you're not losing heat through that method. So if you were to put a warm infant on a cold scale, that would be convection heat loss. Who knows? Why? Yes, it's conduction. Darn it. Am I right about this one? Is it placing infant skin to skin? You guys, I have to look this up. All right. Convection heat loss.
Convection is like the wind.
What happens? Convection is the process of losing heat through the movement of air across the skin. Okay, so water. Which one is it? Right, we're gonna just ignore that this ever happened. Moving on. Ovaries versus ovaries. You were right or you were wrong. Who knows?
So what's the one we need clarification on?
Convection. Which of these is not part of the Apgar score? Appearance, birth, grimace, or activity? This one I do know, just so you all know.
She'll look it up. We'll close the loop on it. Right.
I'll post an announcement regarding heat loss, and then I'll change this for next time. All right, you guys got it. Birth is not one of them. Birth. So activity is one of them. And what is activity referring to? Yeah. Great. So are they pretty close? We used the Apgar scoring. The doctor that created the Apgar scores, her last name was Apgar. And so she made these to fit into the Apgar. It's not necessarily super intuitive. There's different things that we would have used, right? Okay, an infant has a pink trunk, a heart rate of 100 plus, weak attempt at a cry, or tone and slow respirations. What is the Apgar score? Count on your fingers. Okay, so how did we get to 6? Let's go over this. So pink trunk, what is not pink? The extremities, right?
Or
so
just, they can be
acrocyanosis. So you're going to get a 1 out of 2 for that one, okay? Mm-hmm. Almost every baby has acrocyanosis. I've never seen an Apgar score of 10 ever given, okay? So you'll never see a baby that has an Apgar score of 10 even at the 5-minute. All right, heart rate is 100 plus, so that's 2. Weak attempt at a cry is 1, because at least they're attempting, right? Poor tone, 1, because at least they have some. Slow respiration rate, same thing. It's not perfect, but it's somewhere in the middle. And I think that's a really great way for you guys to kind of finagle your way through an Apgar score. Is there something? Is there all of it, or is there none of it? Okay, so 0, 1, or 2. So that equals 6, if I could do my math. Am I correct on this one? Okay, now Molin's here. You're going to see nurses that assign Apgar scores without putting it in a computer, right? Like if I have a critical baby that I'm helping to resuscitate, I'm not thinking in my head what is this Apgar score? And when I'm done, I'll go to the computer and I'll think about it and I'll put it in. In the moment, you just know that infant is not doing well, right? You're I know that this baby isn't breathing. But if you have a good baby, you're going to assign those Apgar scores right there, and you're not needing to use the computer. And so you'll see that a lot. Most nurses won't use the computer to assign it. They're doing it in their head. They're thinking about how this baby looks. But I encourage you guys, you can see it's kind of challenging when you're first remembering how to assign Apgar scores of what looks normal, what doesn't. What is the last sign that a baby is hungry? This is a really good way for you guys to provide education to your patients. Rooting, sucking on hands, or crying. Okay. So if a baby is crying because they're hungry, they're hangry. Okay. Rooting and sucking on hands, those are really good beginning hunger stage signs that you're going to look for, and you're going to help your patients look for them. If a baby has a pacifier in, can you see them trying to root? No. It's one of the reasons that we discourage pacifier use in the first couple weeks. If a baby is strapped in, like swaddled, and they can't have access to their hands, can you see if they're sucking on their hands? No. What are some other early signs that a newborn is hungry and ready to feed? They're like awake, right? Even the first couple days, all they do is like eat, sleep, poop. So if they're awake and they're kind of like looking around, usually a good sign like, I bet they're ready to eat. Okay, so you're gonna help women through this. And breastfeeding is really hard, and your clinical instructor is there to help you. But these are things that you're going to be telling families about. Okay. So if they're crying, they are hangry, you need to kind of help them calm down. All right. What is the minimum time it is recommended to exclusively breastfeed? 1 day, 6 weeks, 6 months, 6 years. All right, so 6 months is correct. We recommend breastfeeding for at least a year. Actually, like the World Health Organization recommends 2 years. Okay, so even if a woman does not, like if she's like, I'm going back to work in 2 weeks, I just don't think that this is sustainable for me, you can have a conversation about hand-expressing colostrum. We know that colostrum actually helps create a barrier in newborn intestines that prevents bacteria from getting into the columnar space in your small intestines. Okay? Now, we talk a lot about breastfeeding. Many of you are formula fed. I was formula fed. We're still going to be okay, right? I think I'm moderately intelligent. But we just know that if you have the opportunity, try to breastfeed if you can. So there's no shaming, right? If someone's like, I'm only going to formula feed, I'm only interested in formula feeding, I think a good place to start is, can you just tell me a little bit about that? And if like they're dead set on it, cool. Okay. If they're like, well, I've heard, then that's the perfect time to like offer some education. All right, ovaries versus brovary. Anyone gonna knock this gal down? I'm assuming it's a gal.
Oh.
Okay. No? No, Maddie, you got this? Oxytocin, adopting, stars? All right, what is the size of the newborn stomach on day 1? Golf ball, ping pong ball, marble, or a dinosaur?
Dinosaur. Why? Let's try.
All right, you guys are mostly right. It is the size of a marble. Okay, that's why colostrum is super thick. It's hard to get out. That's okay. Okay, if your stomach is only the size of a marble, you don't need to do a whole lot. All right, ovaries versus ovaries. Nobody knocked it down. Good job, girl or boy. Good job.
All right, a couple of things. For next week, I'll be in Rochester. I'm also going to be in Rochester tomorrow, so if any of the students in Rochester want to stop by and say hello, I will be there until about 1:30, so I can say hello to everybody then, too. The weeks that I'm not teaching from Rochester, I'll still be there one day, okay? A couple different things. How many of you are doing your reading prior to getting here? Hands high. It's honesty, okay? How many of you feel it's really helpful to do your reading before you get here? It is. The reason being is that just so that you can relax in knowing what's going to be presented versus feeling stressed when we start saying terms that you don't know what we're talking about, right? A lot of these terms are going to seem like foreign language. Those of us that do labor and delivery speak have a different language that we've been talking about for a long time, okay? So I want you to do the reading, and it's really going to be helpful. And a lot of people don't really believe me until they get to the first test, and they're like, what can I do differently? And then we look through whether or not you read or not, and that's usually the issue. I don't want you to have to read every single page verbatim per word. I want you to get like a coffee or a Coke or something that is fun to drink or something. Sit down, take a highlighter, and just go over those really big main words, the big boxes, those kinds of things. That's going to get your brain all ready for what we're going to discuss. And then I'm going to take all that reading, I can guarantee you, and I'm putting it into a PowerPoint, which is an outline for you on what you need to know. But that doesn't mean that none of the questions are going to come from the reading. Okay? So I just really want to be transparent on that now that we're already into week 3. Okay? Your first test is in the next few weeks. Okay? So I just want to make sure, let me know if you have any questions. Okay? And I'll post the link. All right?
I was so ready. Now I'm like,
Okay, yeah, I think it's let me know.